Yes, we can.
Okay, thank you. I would like to welcome you for this third day of our symposium. Today, the sessions will be, we will have 4 sessions. The first 2 sessions with Dr. Anthony and 2 last sessions with me. The first session will be mock code, pediatric and adult. The second, prevention of heart disease in children. The third session will be improving patient experience in cardiorespiratory rehabilitation. And the last one, assessment and rehabilitation of lower limb amputation due to cardiovascular disease. I would like to invite Dr. Antoine to start. Dr.
Okay.
Antoine?
Yes. So hello, everyone. I will start by sharing my screen. You can see the slides, right?
Yes, yes.
Okay. Okay, so I will start. The first session today is about the mock code. So the mock code, which is defined as a simulation exercise with a mannequin or a human patient simulator. So we use a simulator to simulate events that occur in a hospital. This human simulator will have no respiratory effort and no carotid pulse. So it helps to encourage interprofessional teams to collaborate and improve their teamwork as fast response skills. So it's like doing a training to improve the CPR or the cardiac arrest training in order to improve the patient's outcome after a cardiac arrest, for example. That's what we call the mock code. So as you can see on this diagram published by the US San Diego Health System, so you can see that patients that have cardiac arrest in the regular floor, so in non-ICU setting, have a higher chance of survival from the cardiac arrest. While you can see that the curve in dark blue, which is the cardiac arrest that occurs in the ICU setting, the intensive care unit, you can see that the survival to discharge rate is lower. So, and that is a logical consequence because, as you know, patients in ICU have a lot of comorbidities and have more complicated cases as compared to patients present in non-intensive care unit, so in regular floors. So arrest etiologies, most commonly we have respiratory causes of arrest that will cause induced cardiac arrest. We have the circulatory arrest, so cardiac related conditions, and we have the VFib and VTAC. Both these conditions are very, we have had nearly the same percentages in inpatients, so in patients already admitted to the hospital and in emergency department cardiac arrests. So this is in more detail. So the cardiopulmonary arrests, we have the arrhythmias, the VFib or pulseless VTAC that are cardiac in origin, and we have other causes of arrest like respiratory causes of arrest. For intubated patients, we have the most common cause is acute respiratory distress syndrome, which is ARDS. It's usually due to an infection, mainly a lung infection that causes a systemic inflammatory response and will lead to end organ damage and cardiac arrest. For non-intubated patients, we have causes of apnea, obstruction like pulmonary embolism, or progression of a pulmonary disease like lung cancer, for example. We have other causes. We have the vagal cause of arrest. Usually it's a syncope and not a true arrest. Most of the time, we have code blue for patients with a vagal syncope, so it's not a cardiac arrest in this condition. We have the neurologic, so it's due to a stroke, for example, or intracranial bleeding. We have the sepsis, the bleeding, the congestive heart failure. So we have a lot of etiologies for cardiac arrest. As you can see here, another diagram, you can see that the code incidence is most common for arrests that are related to respiratory conditions. You can see the curve on top, which is the red curve, and other conditions are less common but have nearly similar percentages. Here you can see as well, it's another study. So here we have we added the other causes of cardiac arrest. You can see that the percentage and the survival. So patients with the respiratory arrest, even if they are more common cause of arrest, but the survival percentage is better than in other conditions when the arrest is due to a respiratory condition. Okay, so when we talk about sepsis is an infection and a perfusion problem. So we have the bacteria will secrete toxins or mediators that will cause systemic vasodilation. So we'll have a drop in blood pressure, and we have the vasodilation in all our vessels. And the patient will be unresponsive even to fluid resuscitation. So even if we give him a large amount of fluid, the patient will be in shock, in septic shock, so will not respond. So it's due to an infection, and we'll have a high-grade fever, or sometimes we have a paradoxical low temperature. So low temperature can sometimes be an indication of an infection, not just a high temperature that is a sign of infection. And so, as we said, we have low blood pressure, we have a reflex tachycardia, and we have end organ problems. So because of the vasodilation, so blood will not reach the vital organs. So we'll have kidney injury, we'll have heart failure as a result. And you'll have laboratory abnormalities like increase in inflammatory markers, increase in serum creatinine levels. So the primary objective is to treat the infection with early antibiotics, and to give fluids and vasopressors, and to give transfusion if needed. So now we will go into the details of the mock code. So as you know, practice makes perfect. So we always have to make practice in the hospitals, to make training sessions for healthcare professionals in order to improve the resuscitation and the code blue and the cardiac arrest algorithms inside our hospitals. So upon completion of the studies, we will be able to discuss the value of performing mock codes, to describe the importance of getting buy-in, and describe what it takes to implement mock codes, and discuss the importance of delineating team roles. So it's very important to establish this type of codes in all the hospitals. So resuscitation is a high-risk, low-volume team response. So code blue teams should consist of healthcare providers who may not know each other. So not sometimes we are called for a code blue, for example, when you have a cardiac arrest. Sometimes we don't know the other members of the team. So we need to just know our role, and every one of us should do the required job. And they may have limited knowledge of each other expertise. So maybe sometimes the person that is working with us, maybe he's not very well trained for cardiac arrest. So we need to have leadership roles as well. And the variability in role delineation often leads to confusion. So this is why it's important to do training and monthly training to improve all these outcomes. So effective code blue teams, as you know, are associated with improved patient outcomes. So when we need to have rapid code team assembly. So when you have a cardiac arrest, we just have few minutes in order to all the team to be inside the patient room. And the team of the code blue should have a high quality cardiac compression and CPR skills. So everyone should have an ACLS certification in order to perform a CPR. So, and we need to have an effective code team leadership. So the leader of the CPR should have a lot of expertise in order to lead the cardiac arrest. So they did a survey in one of the hospital, and they asked all workers in the hospital is if they have mock codes. So if they have all these training sessions and all these organization, and 46% 60% of participants said that yes, but it was inconsistent. So we're still lacking, even in 2023, we're still lacking in this domain. So we have to put a lot of measures in order to improve the codes and the code blue resuscitation process. And if they also ask them if when they do mock codes, are they multi-professional or nurses only? So is there are doctors in with them? Is there head nurses, not just nurses, or they have practical nurses? So they said yes, the entire team was present, RNs, MDs, and rapid response team, pharmacy doctors as well, in order to verify that the medication are prescribed correctly. So they said that the entire team was present in 61% of cases. So we have 40% of cases that the team is lacking either nurses or MDs or pharmacy doctors. So it's not, it's still not perfect. So we have a lot of studies on effective code blue team developed. You have this study. It's a study that has objectives to see the lessons learned from simulatory studies, to see if these simulation studies are beneficial and they are reducing mortality rates for patients. Another one, you can see this one, another study. And this one is a study that showed that studied comparison of sudden cardiac arrest resuscitation performed data obtained from in-hospital incident chart review and in situ high fidelity medical simulation. And this one as well. So we have this one is for pediatric resuscitation team training. So we have a lot of studies. And this one is in this study that we will discuss now. They check the survival from in-hospital cardiac arrest that occurs during nights or during weekdays to see if we have a higher rate of deaths from cardiac arrest at night or of cardiac arrest during the day. So they included around 58,593 cases. So a big number of, a big sample size in this study. And they aim to see if the arrests that occur during nights have higher mortality rate than arrests that occurs during during days. And they also study the arrest that occurs during weekends. And they found out that arrests that occur during night, so between 11 p.m. till 7 a.m. in the morning, so during the night shift. So during the night shift, for sure, we have different staff that from the staff that are present during the day, and sometimes the staff that are present at night doesn't know the patient correctly, so they are just on duty and they are covering the floor without knowing all patients in details. So they found out that patients that had cardiac arrest at night have lower survival to discharge rate. So they have increased mortality as compared to arrests that occurs during daytime. So the daytime and evening. So arrests that occur between 7 a.m. and 11 p.m. have higher chance to survive than arrests that occurs from 11 p.m. till 7 a.m. And this was due to staff that was less, we have less staff at night and less resources. And sometimes the staff at night had less experience, mainly because of the lack of knowledge of the patients in details and patient history. So this was very important and they tried to improve it. Same, they did another study that was published in the Journal of Critical Care Medicine. And in this study, they asked the residents, so the medical residents, if they feel that they are unprepared and unsupervised as leader of cardiac arrest in teaching hospitals. And the result was positive. There was not the proportion of residents that felt unprepared and unsupervised was higher than the residents that feel that they can take leading roles. So it's very important as well to improve leadership skills, not just technical skills for these residents or doctors. We need to improve also the leadership roles in order to improve the code blue process. So this study as well that was published in 2016, they studied the survival rate of cardiac arrest that occurs during night as compared to cardiac arrest that occurs during the day, and they included here 27,700 patients age above or equal to 16. And the database was taken from the UK, United Kingdom. And they had a similar result as a previously published study in the previous year. So not much has changed. So we didn't improve a lot in this field. So still you can see here that nighttime cardiac arrest have higher mortality than cardiac arrest that occur during daytime, even during weekend daytime. So nighttime still has a higher mortality rate. Even arrests that have that happens at night, there is a spontaneous return of circulation. So ROSC, it usually takes more than 20 minutes. So even if the patient survive at night, he will have a lot of neurologic manifestation because the CPR took a long time in order to regain spontaneous circulation. So they will have neurologic deficits, and sometimes this patient will stay intubated and we will not be able to wean them off from the ventilator. So there's a big difference in day to night time survival. Here it's the same thing. It's calculating the odds ratios, but it shows the same results. So as we said, nighttime arrest had higher mortality as compared to daytime arrest. We need to have ongoing multidisciplinary training program. We need to have regular scheduled mock codes in order to train our healthcare professionals. We need to have initial and annual individual team role training. So when we assign a new healthcare worker, initially we need to add him to this multidisciplinary training program and then have yearly training with him. We need to have leadership training for doctors and for residents that are on duty, especially during nights, because at night, the attending doctor is usually most of the time not present in the hospital. The resident or the medical student will be present in the hospital to cover the floors. And we need to have all our professional or all our member of the Code Blue to be ACLS and BLS certified. Every healthcare worker should have ACLS or at least BLS certification. But this is not enough. We need to make also training for CPR. We need to have CPR training, frequent CPR training, and frequent CPR knowledge, because as you can see, you will see this is the next study. Because if they do training for CPR every 3 months, this will decrease the time to start chest compression from 33 seconds to 13 seconds. So if the staff is not well trained, it will take 20 more seconds in order to initiate CPR, and it will take 157 seconds instead of 109 seconds in untrained healthcare worker to initiate defibrillation. So, and every second lost in the CPR and the cardiac arrest is increase in mortality. So it's very important to do training sessions for CPR every 3 months in order to decrease start chest compression. So to start CPR faster, 20 seconds faster, and to start defibrillation faster. So we gain 50 seconds by training our healthcare professionals every 3 months. As you can see here in this study also was published in a critical care journal. You can see that maintenance of CPR competency. So here is the start is at day 0. So we can consider that directly after the training, the healthcare provider has 100% skill. But after 3 months, you can see there will be 70% drop in skills. So the healthcare doctor or nurse will lose 70% of the skills of CPR. So, for example, they will not be able to do adequate compression. They will not be able to do adequate ventilation for the patient. And as we progress, so if we don't do training for 6 months or 12 months, you can see that we will lose 90% of our CPR skills. So it's very important to initiate training just 3 months after the first training. So we need to make a lot of training in order to improve, especially nighttime cardiac arrest survival. So we have to do orientation for new staff, as we said, and we need mainly for critical care workers. And we need to do training for unit-based. So in each unit, we need to do the training because, as you know, arrests in the ICU are different than arrests that occur, for example, in the emergency department or in another floor. And we need to have a simulation center. Every hospital should have a simulation center. So we should have a model, a human model, so a plastic model, in order to train our healthcare worker, as we can see in the pictures on the bottom. And we need to train residents, so doctors, in order to improve their leadership skills. Okay, so here's you can see that top performing hospitals. This was a study published in Circulation in 2019. These hospitals, so they have team design, they have team composition and team roles, they have communication and leadership during in-hospital cardiac arrest. So communication during a cardiac arrest is very important because everyone should know his role, and the leader should assign the role of all the participants, all the participants of the CPR and the cardiac arrest, in order to reduce mortality. And all these top performing hospitals, they have training and education programs every 3 months. So the purpose is these resuscitation drills. So this simulation is to identify any system issue. So when we do a training and simulation, we will know what we are lacking. So we will know, for example, we are lacking, where we are not doing good compressions, we are not doing good ventilation, we are taking a lot of time to initiate CPR or to initiate defibrillation. We can know this by doing the simulation. And we need to assess and evaluate team roles. So everyone should know his role. So before the arrest. Okay. So here are the equipment. We should have human plastic equipment, and we should have defibrillators in order to train our healthcare workers. And these mock codes that we are discussing now started in 2007, and they should do a lot of training. So sometimes we ask them to do 4 times per month, day and night shifts. So we do a simulation during the night shift, for example, or during the day shift. And we need to have adult and pediatric scenarios, not just adult, because as you know, pediatric patients also can have cardiac arrest. So we need to train our healthcare providers in order to be ready for adult and pediatric scenarios, not just adults. And at the end of the simulation or at the end of the cardiac arrest, it's very essential to do a debriefing. And everyone should have his opinion and to give his opinion on how to improve the system. We have 2 types of simulation. We have the low fidelity simulation. This is in hospitals that don't have a big budget. They can have an equipment that is less expensive, but it's more mobile. So you can see this equipment is less expensive, and we don't need a lot of staff resources to run the simulation. So we just need 1 or 2 people in order to run the simulation. In case of a low fidelity simulation, it doesn't take a lot of time, so less planning time. But the coordination is a bit decreased, and we have more effort here to collect the data, and we have manual data collection because it's a low budget simulation. But if we compare it to a high fidelity simulation, here we have a high budget. So for the simulation, so we have better equipment. The equipment is more expensive and it's more heavy, so we can't move it easily. So we need to have rooms, just rooms for simulation. We can't do it on any place like the low fidelity system. And we need tech and educator support. So we need more than 1 person in order to run the simulation, and we need technology in order to run the simulation. But here the scenarios are more realistic. So they are more, they look more like the real cases. So they increase the critical thinking, and they decrease time to staff initiating code blue intervention. So the new ACLS now training all are based on high fidelity system. We have all these new equipments, and we have the technical support in order to initiate the simulation. So Okay, so we need to have a checklist. So we need to check the after the CPR. We have someone just to have a row of checklist to assess the compression quality, to assess the defibrillation quality, and to assess the ventilation quality. This person will also need to check for if the lead is a person that is the code blue leader, if he has a good leadership skills, if he's assigning good roles, and he need to note that time of pulse check if we are checking the pulse correctly. So every 2 minutes we need to check the pulse. If we are counting our compression, so every 2 minutes we need to do compression for 2 minutes, then stop, then check the pulse. And in case of a shockable rhythm, we need to do defibrillation, and we need to ventilate our patient and intubate the patient as soon as possible. So we need to have a checklist to know if all these things are being done in order and efficacy. So data collection is very important in code blues, and we should have a person that is responsible for collecting all these data. So as we said, debriefing after the code blue, so after the cardiac arrest or even after the simulation, is very important. And we need to ask this question. We need to ask if all went well, if we had the problems during the procedure, and what could the team do differently next time in order to improve? And is there any safety or equipment concerns? So if the defibrillator is working correctly, is the oxygen machine is working correctly? Is there a safe environment or places and we need to challenge to see what are the challenges in the debriefing. So the debriefing is very important in order to improve our next code blue, for example, or next cardiac arrest, especially as we said, during nighttime cardiac arrest. So we need to focus on CPR quality, defibrillation quality, slow down assisted ventilation rate. So we'll see later in the next slide that we don't need to do a lot of ventilation during cardiac arrest. So we just need to do 10 ventilation per minute, and need to focus on the leadership roles. And this is, for example, as you can see here, it's a room or simulation room. It's a mock-code simulation room. You can see that we have the monitor here that will show the rhythm. We have the blood pressure measuring on the monitor. We have the heart rate. We have the all these healthcare professionals. We have the team leader. We have the person that is responsible for the ventilation, the patient that is doing the CPR. So we have the person that is collecting the data and measuring the cycle times. So everyone has a role. So in most hospitals, for example, this is a US hospital, you have, if you count the ICU attendings and intensive care residents, we have 60 doctors working in the ICU. We have 40 ICU registered nurses. We have 50 anesthesiologists. We have 25 pharmacists, and we have 28 recorders, and we have 22 RNs that are responsible for the defibrillator, and you have 18 registered nurses that will do the rapid response team. So between all this number, if we do all the combination possible, we can have 11 billion different combinations. So we can have theoretically 11 billion team in order to do the CPR. So we are not lacking. So we need to just select our teams because every hospital have these number of similar numbers of workers. So if we do the combination, we can create different teams. And we need to also, during the arrest, we need to notify the lab worker, because sometimes we need to do urgent blood test or urgent blood gases in order to get a diagnosis of the cardiac arrest. We need to notify the nursing supervisor of the hospital. We need to notify the security to just prevent the family, for example, for entering the room. And we need to also call the family in order to tell them that the patient their patients is in a critical condition. So we need to do all this. And this is if you see this picture, we have the patient in the middle. We have the compression provider that should be on the right side of the patient. We have here the bedside registered nurse that will administer the medication. We have the recorder that will note everything on the checklist. We have the code leader that should be in front of the patient. Usually it's a supervising medical doctor or a head nurse. We have another operating nurse that is next to the team leader, and we have sometimes the pharmacist. So as we said, the PharmD is the pharmacy doctor, and we need a nurse here to make the defibrillation, a nurse or a doctor, and we need a nurse as well in order for the ventilation, and an anesthesia if we need to make an intubation. So this is the Code Blue team structure that should be present in all hospitals and during every cardiac arrest. And this should be predetermined. So before the occurrence of the arrest, every member of the team should know his role perfectly. So here is another picture of a simulation room. You can see that we have a leader here. We have the nurse that is responsible for the medication administration, the anesthesia, the ventilation. So we have the pharmacist. So we have all the members present during the simulation. Okay. So sometimes when we call for a Code Blue, you can see that all the hospital will arrive for the Code Blue, and this should not happen. Just the team that is responsible for working in a cardiac arrest, the Code Blue team, should be present in the room. Not every healthcare worker should arrive to the room to avoid this crowded condition, because crowded condition will decrease our attention and will increase mortality in cardiac arrests. So the nursing supervisor is responsible to control the crowds. So we need to have a nursing supervisor responsible for just allowing the Code Blue team to enter the room. Okay, so what we're still lacking with the mock code. So we said that we have high fidelity that require higher budget, and we have low fidelity. So high fidelity for sure is better, but it's not readily available in all hospitals and in all healthcare system. So still in some places they do not take the mock code seriously, and when we do these trainings and this simulation, we will, for example, the nurse or the doctor will be away from its floor, so we will have a shortage of nurses in floors when there is a simulation. And sometimes the data collected in this simulation are not realistic, because as you know, simulation is not like the real-time cardiac arrest and the real cardiac arrest. Sometimes the simulation, we tend to have different numbers than the case of cardiac arrest, just because of the stress or the stressful situation of the cardiac or real cardiac arrest. It's a bit different in terms of data collection. So we will now talk a bit of real-time cardiac arrest, so not just a simulation. So you can see that out of hospital cardiac arrest in the United States, we have around 350,000 adults per year that will have out of hospital cardiac arrest. So just 10.5% survival rate when the arrest occur outside the hospital. And in case of in-hospital cardiac arrest, we have around 292,000 per year of in-hospital cardiac arrest. So just 1 to 2% of hospitalized patients will have cardiac arrest, and 26.7 will recover after the cardiac arrest. So you can see that cardiac arrest inside the hospital, it's better to do a cardiac arrest inside the hospital as compared to cardiac arrest outside the hospital due to high survival rate. And this is due to the implementation of codes and training sessions and simulations for healthcare workers. So it's very important to have a high quality CPR with minimal interruptions. So we need to do the correct cycle of CPR. So 2 minutes without any interruption for 2 minutes. And then after 2 minutes, we need to check the pulse. If we have pulse, if we have the pulse, then we stop the CPR. If we have no pulse, but we have a rhythm on the monitor, so sometimes we need to do defibrillation in order to shock the patients. And if we still have, after the defibrillation, we should continue another cycle of CPR for 2 minutes. So the most important thing is do not interrupt the CPR during these 2 minutes. So as you can see, see here, we need to do adequate CPR. Why we need to do adequate CPR? Because when we do adequate CPR, we'll increase our coronary perfusion pressure. So the goal of the CPR is to increase our coronary circulation in order to prevent myocardial death. So when we do adequate CPR, so we need at least 15 millimeter mercury of coronary perfusion pressure in order to achieve survival after cardiac arrest. So if we achieve 15 to 25 millimeter mercury of maximum coronary perfusion pressure, we increase our survival from return to, so we increase our return to spontaneous circulation by 46%. And if we increase pressures up to above 25, so with a very adequate CPR, we increase the return of spontaneous circulation to a rates of 79%. So CPR quality is very important in order to improve survival after a cardiac arrest. So we need to, when we do the CPR or chest compression, we need to achieve a rate of 100 to 120 compression per minute. And the depth should be between 5 to 6 centimeters. So we should go down in the chest by 5 to 6 centimeters and have a full recoil. So it's very important, and we need also to do adequate ventilation. So we need to do, for example, every 30 compressions, we need to do 2 ventilations and give a tidal volume, so an inspiratory volume between 500 to 600 milliliters, and just for 1 second ventilation. We just don't need to keep pressing on the ventilator. We just, to the ambu bag, we need to just do it for 1 second and give a volume of around 500. Okay. So now you can see here on this slide. So when we do a 100 to 120 compression per minute during the CPR, we increase our survival. So there's a survival benefit of achieving 100 to 120 compression per minute. As you can see, if we have lower number of compressions, the survival is less, so 8%. 8%. And if we do a lot, so more than 140 compression per minute, it's not good. So the survival will not be will be lower than if we do it between 100 and 120. So we need to try to have 100 to 120 compression per minute. Same here. This is another study published in the Circulation Journal. It shows that if we do compression, so we go to a depth of 40 millimeters to 55 millimeters, so between 4 and 5.5 centimeter, we have the maximum survival rate after the cardiac arrest. So this curve, this here, this one here, and this one here, and this one here. So you can see that for these three, between 40 and 55, they had the higher survival rate as compared, for example, to compressions between 25 to 29 millimeters, so 2 centimeters only. This has approximately 50% less survival. So it's very important. So not just the rate should be counted correctly. Also, the compressions should be between 40 to 55 millimeters. So here is another study as well. It shows that compression between 50 to 60 here are likely to be associated with greater survival than compressing to other depths. So we can say that it's safe to compress between 45 to 60 millimeters in order to have the better survival for our patients. Here is another study as well, shows that if we do compression, that it was published in this journal in 2013 in Resuscitation Journal. It shows that if we do compressions of more above 6 centimeters, we increase iatrogenic injury. So we increase the risk of rib fracture. We increase the risk of, for example, myocardial rupture. If we fracture the rib and the rib can cause a rupture in the heart, so we have a tamponade associated to this. This increase in depth. So we need to try to train our healthcare professional to do the compressions adequately. So here it's another study that shows that assess the release velocity. So you have the compression. So when we go down to the chest, and we also have the release. So when we remove our hand from the chest and we go up. So in this study, it showed that fast release was associated with better survival as compared to slow release. Okay, so you can see here this one, it's the fast release. It was associated with survival of 23% as compared to slow release, which was associated with a survival of just 7%. So we need to have fast release. We need to do this, need to do it in a fast way in order to increase the survival. So all these small details, if we combine all these small details, we will have a significant increase in survival after a CPR. So you can see here, you do the compressions, we go down, then we release, we go up, then we go down again, and then we go up. So we need to go up fast. We don't need to take a lot of time by going up. So now, what are about the pauses that we take during the CPR? In this study that was published in the resuscitation journal, we can see here that there was no near relation between pause time and shock success. So here, when they have pauses of less than 10 seconds, you can see on this first one, the success of the CPR was a lot higher than if we delay the start of the compression. So we need to start compression as soon as possible. Sorry. Okay, so this is another study as well. It was published in the same journals for the impact of peri-shock pauses on survival. So as you know, sometimes we need to do a shock, so a defibrillation, because we have a shockable rhythm in order to try to convert this rhythm to sinus rhythm. So if they found out in this study that survival to discharge significantly improved when pre-shock pauses were less than 10 seconds. And peri-shock pauses, so pauses after the shock, were less than 20 seconds. So we tend to see sometimes a lot of time wasted on between the last compression and the defibrillation. So we need to try to minimize this time to less than 10 seconds. And after just the defibrillation, we always have to continue the CPR. And we just have a delay. This should not take more than 20 seconds in order to continue CPR. So it's very important to have a trained healthcare professional that is trained to manipulate the defibrillator in a correct way. Now the ventilators, we said that for the ventilators, we should achieve around 10. So we need to do one ventilation every 10 beats, or 30. For every 30, we need to do 2, and we need to provide 500 to 600 milliliters, or 6 milliliter per kilogram. And the duration of the ventilation should just be 1 second. So every ventilation should have just 1 second in time. In this study, they studied the impact of hyperventilation on hemodynamics and on survival. So as you can see, if we increase the ventilation during the cardiac arrest, we'll have decrease in survival. So we don't need to do a lot of ventilation during CPR. Otherwise, we will increase our mortality after the cardiac arrest. And in this study, was recommended by the American Heart Association. You can see that on this graph, I will put the laser pointer. So you can see that this red line is the recommendation from the American Heart Association. So the mean ventilation rate, as we said, we should do 10 breaths per minute. So this is the recommendation. You can see that in real-time cases in the hospital, there's a lot of cases that we do more. So we reach 20 breaths per minute, and sometimes less, 5 breaths per minute. So we're not following the recommendation most of the times. Same applies to mean tidal volume. We said we need to give between 500 to 600 milliliter for each ventilation we give. But you can see that in the real-time scenarios, most of the times you are giving a lot less. So you can see that the proportion of this graph is a lot important below the red line. So we're not giving adequate ventilation. And the mean minute volume is the liter per minute of oxygen that we give. It should be 6 liter per minute, but you see that we have a lot of variability in the hospitals. So the guidelines are well known, but it appears that in practice, they are not well followed. This is the importance of mock codes in order to improve all these numbers. So same here for hyperventilation. You can see that cardiac arrest patients were ventilated twice faster than in guidelines recommendation in most of cases. So this has a decrease in survival rate. Same here for long ventilation duration. So we said we just need to give 1 second of ventilation. So here we see that they gave, for example, average of 4 seconds for ventilation. So this will leave little time for the development of negative intrathoracic pressure. So if we give a lot of ventilation, we will have different interthoracic pressure during the cardiac arrest. So this will prevent the return to spontaneous circulation, because we need to have a negative intrathoracic pressure to improve our coronary circulation. So we need to have, in order to improve all of these, you need to have a CPR coach, we need to have real-time CPR feedback, we need to have debriefing, and we need to have system-based approach. So we need to have guideline-based approach and to follow the guidelines. So we'll repeat this. So the CPR coach role should assign all these positions. So we have the patient in the center, we have the nurse that is responsible for the airways, so to give the ventilation. The nurse should open the airway, should provide the mask for the ventilation, and should insert airways adjuncts as appropriate. So after that, you can see here we have the person that is responsible to do the compression. So everyone should be able to do 2 minutes non-stop compression, and after 2 minutes we can rotate, we can bring another person to do the compression. But everyone that should participate in this CPR should be able to do at least 2 minutes of non-stop compressions. The team leader should be here, so should be on the left side of the patient. We have the CPR coach, so this is a simulation event. It should be monitoring if the compression are being done correctly. And we have the person that is responsible for the recording and the timer. So this person will say that we're at 2 minutes, so we need to check for pulse, and we need to rotate between the compressors. So CPR feedback is to do real-time CPR feedback. So during cardiac arrest, sometimes they record it in real time, and there's someone monitoring the process to detect any deficiency in the system. So this study was about the impact of training and real-time CPR feedback, so on survival. And they studied, so the real-time monitoring is to assess the CPR quality and to assess the survival to hospital discharge. And you can see the results in this study. So the first case was a patient that did not survive, and this patient didn't have a real-time CPR feedback. So the event wasn't recorded, and there's no real-time feedback. And you can see the reason of this case is because we had shallow compression, so inadequate compression, less than 100 to 120 beats per minute. And we had compressions that did not go deep to 5 centimeters. And they had, so as we said, fast rate, low compression fraction, and they had long pauses. So we said we just need to have pauses of less than 10 seconds, not more, between this compression and the defibrillator process. So the case number 2 was a survivor. So this patient, they had a real-time CPR feedback during the procedure. And this allowed the healthcare provider to do good depth CPR with a good rate, so between 100 to 120, and high compression fraction, and the code was very organized. So real-time CPR monitoring is very important in order to improve the cardiac arrest procedure. And you can see this topic was published in the Journal of Critical Care about CPR feedback and on guideline compliance to check if we are following and compliant with the guidelines. And you can see here that CPR with feedback is the chart that is light blue, and the CPR without feedback is the CPR with colored dark blue. And you can see that the ventilation quality was very, very high in patient with CPR with a feedback, so the real-time feedback. The ventilation quality was correct in 94.3% of cases. So we had correct ventilation rate, we had correct tidal volume, so we are giving 500 to 600 milliliters, and we are giving 10 beats per minute, and just duration of 1 second. So this showed that real-time feedback was associated with improvement of ventilation quality, and it was statistically very significant. We had a p-value that is very significant, so 0.0001. So it's very significant, and we have to do it. So the debriefing, as we said, so it should happen after the arrest, and this was published in the 2020 AHA guidelines. So performance-focused debriefing of rescuers after cardiac arrest with review of objective and quantitative resuscitation data can be effective for both in-hospital and out-hospital system of care. And this is class 2A, so it's recommended to do it, to do debriefing after the cardiac arrest. And this is the impact of post-event debriefing. So post-event debriefing will help educate the healthcare workers and improve their skills. So you can see here that with debriefing, we have more results, spontaneous return to circulation and survival was increased as compared to no debriefing. Same thing here, you can see that survival was increased. So the dark gray here, you have increase in survival if we do debriefing post every CPR session. And we will have a lot of patient discharge, so with no deaths, they will be discharged home after a few days if we do debriefing, and the patients will have good neurologic quality, so they will tend to have less neurologic side effects post CPR, because neurologic side effects are very common after a cardiac arrest. So we reduce around 50, we reduce half the neurologic complication if we do debriefing after each CPR session, because we will form a better quality team with the debriefing. So as we said, we need to have a system-based approach and need to follow the guidelines. Here is, I think it's the last slide. So you can see that another study published in 2015, this study showed that high quality CPR will impact outcome. So you can see that with the improvement of the CPR quality, so if we are doing the compression correctly, if we are doing the ventilation correctly, if we are doing the defibrillation correctly, you can see that the percentage of survival will increase from 20% to around 45%. So it's a very big improvement, and it will improve year after year after the implementation of the mock code and the simulation sessions and all the trainings. So thank you. This was my presentation. If you have questions, I'm ready to answer.
Thank you, Dr. Antoine. Any question? Thank you, Dr. Antoine. Okay, we will go for 5 minutes break. Okay, there is a question, I think, from Fatma Al-Kanan.
Yes. Okay, so is there a big difference CPR during open chest? So during surgery, you mean you mean open heart surgery, right? So sometimes okay, so sometimes usually when we do open chest CPR, sometimes when we do the surgery and we close the chest after the operation, sometimes we'll have cardiac arrest, and usually it's due to bleeding in the pericardial area or due to cardiac tamponade post-procedure. So most of the times when we have cardiac arrest post cardiac surgery, we need to open the chest even inside the room of the patient. Sometimes we don't have time to go to the OR operation room, so we need to open the chest inside of the room, and we need to do open chest CPR. For sure, open chest CPR has a higher mortality as compared to CPR that was done in the normal conditions.
Any more questions? Thank you, Dr. Antoine.
Okay, so we take 5
Any
minutes.
other question?
No.
Yeah, I think it's okay. We can take 5 minutes break.
Okay.
الوقت ترتاح وتشرب نقطة مي. Thank you so much.
Okay.
Okay, so we will be back in 5 minutes.
Okay. The second, we will continue with the second presentation of today, which is about prevention of heart disease in children. Do you see the slides? Are you able to see the slides?
Yes, it's clear.
Okay. So I will start. Prevention. So coronary disease among in order to study the cardiac disease in young individuals, and this very old study, this study was published in the 1950s about coronary disease among United States soldiers killed in action in Korea. So they did autopsy for these soldiers that were killed. They did 300 autopsies. Soldiers that were killed were in their early 20s, so they are young patients. So they did autopsies for them, heart biopsy, I mean, and they found out that 37.3% of the hearts and 77.3% of the heart, they have evidence of coronary atherosclerosis. So atherosclerosis was starting very early in life. So it's not just a disease of the old population. It starts at very early ages, even ages below 10%, as we will see, as ages below 10 years, as we will see in the next slide. So you can see here that they found out that all these soldiers that were dead after doing the autopsy, they found out that 13.3% of these soldiers have coronary plaques of 10%. So they have narrowing of their coronary artery by 10%. And 6.3% of these soldiers have narrowing of 20% of their plaques. As you can see, we can find as well around 90% narrowing in very young individual, asymptomatic individuals. So there's 5.3% of these 300 autopsies that showed 90% coronary artery narrowing. So, and we have 3% of these soldiers that had complete occlusion of one or more vessels. Okay. So here is the autopsy image. So under microscopy, they studied these images. And this first one, it shows a cross section through anterior descending artery. So this is the main and left anterior descending artery of the heart in a 22-year-old white man that was killed by penetrating wound. So he was killed in a war. But so it was a headshot, so it has nothing to do with the heart. But surprisingly, they found out that this soldier had a coronary artery plaque of more than 90%. So it's almost occluding the vessel. You can see that the lumen of the vessel is just this area. So he had a plaque that is obstructing the vessel. This was in a 22-year-old asymptomatic healthy soldier. And in figure 2, they found that also in another soldier, a large plaque in the anterior descending artery, also in a 22-year-old American soldier that was killed in Korea. So same thing, they found out surprisingly this huge plaque and nearly obstructing plaque. So this is another article. So it showed that this widely cited publication dramatically showed that atherosclerotic changes appear in the coronary arteries years and decades before the age at which coronary heart disease becomes a clinically recognized problem. So years before myocardial infarction occurrence, we'll have progressive development of atherosclerotic and high cholesterol containing artery plaques. So it starts at an early age. In the pediatric age, we start developing our cholesterol plaques. And the morphologic alteration described were observed in the coronary artery obtained. This was another study. So 100,500 United States battle casualties in Korea. So also death soldiers in Korea. And they did 1,500 coronary artery. They acquired the coronary arteries and they did autopsy. So they studied these arteries under electron microscopy between 1954 and 1960. And they found out that almost all persons in this study have aortic fatty streaks starting by age of 10. So by the age of 10, we can start to have deposition of fat inside our main vessels, inside the aorta, for example, inside the coronary arteries. So here is also another study they studied patients that died between the ages of 3 and 26 years, and they found that the overall trend to increasing mean surface involvement with fatty streaks according to increased level of LDL cholesterol was impressive. So they found out that patients with higher number of LDL level have increase in cholesterol deposition inside the vessel. And you can see in this curve, so when we have for example, LDL level between 40 to 60, we just have 40% of the vessel surface is covered with cholesterol. But if we have LDL level of 120 to 140 at a young age, we can have around a plaque, for example, of 40%. It will decrease the surface of the vessel by 60%. So even in young patients. So all these patients were patients that were young. So as we said, between ages of 3 and 26. So atherosclerosis is a disease that starts in the pediatric and the early adulthood population. So this is another one. So they studied the atherosclerosis in use, and we have also another. You have a lot of studies studying this same topic. So here is a pathologic determinant of atherosclerosis in use risk score. So in this study, they established a score in order to see who are the pediatric patients that are at a high risk of developing cholesterol plaques at an early age, and this will predispose them to adulthood coronary artery disease and heart disease. So in this study, they created this score. It's called PDAY risk score for predicting advanced atherosclerotic lesions especially in young population. So as you can see in this score, we have modifiable risk factors. So we have, for example, the non-HDL cholesterol here. See LDL, for example. If we have LDL level between 190 to 119, for example, we have a score of 6. Same for HDL. If we have a high LDL, we can have a score of -1, so we will improve our score. If the pediatric patient smokes, we'll put a score of 1. If the blood pressure is high, we increase the score by 4. Obesity is very important as well. If the BMI is above 30 in men and it's a score of 6, but BMI, but obesity in young females was not associated with atherosclerosis, because we know that the premenopausal females are protected from have hormonal protection against the development of atherosclerosis. Same for hyperglycemia. If we have hemoglobin A1C of more than 8, we increase the score by 5. Okay. So at the end, we will, for example, if this patient was a smoker, was hypertensive, and had a BMI of above 30. So this patient had a score of 11. And if you look at this graph, a score of 11, for example, in a patient aged between 15 to 19. So this black, I will put the pointer. So if the patient is aged between 15 to 19, for example, and has a score of 10, he has a probability of around 5% to have an advanced atherosclerotic lesion. Okay, so, and as we grow older, we increase the probability of developing atherosclerosis depending on this score. So the score is very important, especially for young patients, in order to predict the onset of atherosclerotic lesions early on in life. So even in 15 and 19-year-olds, atherosclerosis has begun in a substantial number of individuals. And this observation suggests beginning primary prevention at least by the late teenage. So we need to start screening these patients that are at risk, for example, obese, pediatric patients, patients with high blood pressure. You have a lot of pediatric patients with high blood pressure. We have pediatric patients with diabetes, especially diabetes type 1. So all these patients should be screened, and we should calculate this risk score in this population in order to prevent or retard progression to more advanced cardiac coronary artery lesions. So this is also another study. They studied the endothelial function in healthy 11-year-old children after dietary intervention with onset of infancy. So in these patients, they started lifestyle modification by changing their diet from infancy. And they followed them over the year, and they concluded that a low saturated fat diet that was introduced in infancy and maintained during the first decade of life, so between 1 and 10 years of age, is associated with enhanced endothelial function in boys. So we improve our endothelial function. Endothelium is the component of the blood vessels. So we'll improve the health of our blood vessels. And this effect is explained in part by the diet-induced reduction in serum cholesterol concentration. So as we improve our diet, we will drop our cholesterol level. And by dropping our cholesterol level, we decrease the atherosclerotic process, we decrease the atherosclerotic plaques that will be deposited in the vessels. So we improve the conditions in general, especially if we start it at a young age. Sorry. Okay. Okay, so this was another article as well talking about the same topic. So atherosclerosis began in childhood and progressed during adolescence and young adulthood. And almost all persons have aortic fatty streaks, as we said, by age of 10. And if you see, you can see here, so this is age between 0 to 10. You can see that usually there is no fatty streaks deposition in the first decade of life. But after the age of 10, so between 10 to 20, we will start to have fatty streaks. So we will have to start have narrowing of the blood vessel lumen of at least 10%. And as we grow up, so between 20 to 30, the plaque will increase in size. And finally, the plaque can rupture and cause complete artery occlusion. And this will lead to myocardial infarction, to stroke, to gangrene, and to aortic aneurysms. We're not just mentioning the coronary artery vessels. This process can happen inside any vessels in our system. So not just the coronary artery. It can happen in the brain. It can happen in the lower limbs. It can happen in the abdominal aorta. So it's very important to risk stratify these patients, especially patients between 10 to 20, so pediatric and adolescent patients, because if we find patients with high risk, we can implement a lifestyle modification for these patients in order to prevent the progression of the disease between age 20 to 40, because if we stop the disease progression between 10 to 20, we will delay the onset of myocardial infarction later on in life, or even reverse this process and eliminate the cholesterol plaque that is initially formed between age 10 to 20. So here is a historic case. It's a very old case in 1996. So you can see this is the distal left anterior descending artery. It's a coronary artery, the main artery. And 3 years after implementation of a healthy diet, you can see we had reversal of the cholesterol plaque, and we have almost complete resolution of the disease. And you can see that the diameter of the artery has gone up. Here is a more recent, this is a recent study about physical activity. So here we are talking about lifestyle changes, even in pediatric population. So physical activity in children who engage in higher level of physical activity, so during early childhood, they have better health indicator with more intense activity. So this will attenuate the stiffening of our arteries. So stiffening of our arteries will cause hypertension. So by doing physical activity, mainly at a young age, we will prevent the development of hypertension at adult life. So it's not just the diet, we need also to implement physical activity, especially for obese pediatric patients. Okay. So now I will focus on the high blood pressure and hypertension in pediatric patients. So why we will focus on high blood pressure in pediatric patients? Because numerous studies have shown that elevated blood pressure in childhood increases the risk of adult hypertension and metabolic syndrome. As you know, adult hypertension and metabolic syndrome is associated with coronary heart disease, heart failure at an early age. So youth with high blood pressure levels in childhood are also more likely to have persistent hypertension as adults. So when the hypertension develops early, for sure at adulthood, they will have persisting hypertension and even exacerbation of their hypertension. And young patients with hypertension are likely to experience accelerated vascular aging. So because like we said in the previous slide, we'll have the endothelial dysfunction related to hypertension. So, and we have increase in blood vessel stiffness. So the aging of the vessels will increase significantly. Okay. So how can we define hypertension? So hypertension, we have a lot of factors that are incorporated in the evaluation of hypertension. We have the sex, so it's a bit different between males and female. We have the age and we have the height as well. So we need to study all these factors combined. And we see here that normal blood pressure in children age 13 or above should be less than 120 to 80. So 120 systolic to 80 diastolic millimeter mercury. This is the normal blood pressure. Elevated blood pressure is when the systolic blood pressure is between 120 to 129 millimeter mercury. So this is a elevation of, we call this elevated blood pressure. So here we need to start to implement diet modification and physical activity in order to try to reverse this condition, try to reverse blood vessel stiffness, and try to reverse the atherosclerosis. Because usually when young patients develop hypertension, most of the time they have associated elevated level of cholesterol as well because of their unhealthy diet. Stage 1 hypertension is defined as systolic blood pressure between 130 and 139 millimeter mercury, and diastolic blood pressure between 80 to 89 millimeter mercury. And stage 2 hypertension is a blood pressure that is above or equal to 140 systolic to 90 diastolic millimeter mercury. And these values are based, they did these guidelines, they studied the 50,000 children and adolescents, and they came up with these numbers. Okay, so this is for children above 13 years of age. Okay, so in the US and Europe, the diagnosis of persistent childhood hypertension is made when repeated blood pressure values on 3 separate visits. So we need to do 3 separate visits to the doctor, to the pediatrician, or to the pediatric cardiologist, and the doctor should measure the blood pressure in these 3 visits. And if the mean blood pressure measurement is above 13 systolic to 80 millimeter diastolic, we can make the diagnosis of hypertension in pediatric patients. So we should measure blood pressure frequently, and we should measure it annually in children and adolescents of 3 or more years of age. And it should be checked in all children and adolescents of less than 3 years of age at every healthcare encounter if they have obesity. So if they are 3 years or more, we need to check their blood pressure annually, even without any associated comorbidities. But if they have less than 3 years of age, we need to check their blood pressure if they have associated obesity, or if they are taking any medications that is known to increase the blood pressure, or if they have renal disease, because renal disease can cause is most of the time associated with a fluctuating blood pressure, and if they have a history of aortic arch obstruction or coarctation or diabetes. So above 3 years, every year we should measure their blood pressure on average. But less than 3 years, we should measure their blood pressure if they have associated conditions that promote hypertension. So as we said here, we have other conditions other than obesity and diabetes, and the thing we said, if they have congenital heart disease and they are less than 3 years, we should measure their blood pressure repetitively or every year. If they have recurrent urinary tract infection, because repetitive urinary tract infection can cause kidney disease, so they predispose patients to have hypertension. So renal disease, urologic malformation, if they have family history of congenital renal disease, if they undergone solid organ transplant, if they have malignancy or bone marrow transplantation, if they are treated with drugs that cause high blood pressure, or if they have other systemic illness associated with hypertension. So we have a lot of systemic conditions, rare conditions, some autoimmune conditions. We have, for example, neurofibromatosis, which is a disease affecting the skin and many organs. We have the tuberous sclerosis, and we have the sickle cell disease. Sickle cell disease is a disease affecting the hemoglobin. So we will have breakdown of hemoglobin because the shape of the hemoglobin is abnormal. We have here what we call the hemoglobin S. So there's a risk of hemoglobin breakdown, and this disease is associated with a lot of vascular dysfunction and high blood pressure as well, especially in young population. So in all these criteria, we need to check the blood pressure even for patients that are younger than 3 years of age. So the measurement of the blood pressure in the young is a bit different than the adults. So here we need to have different cuff size of the machines that we will use to measure the blood pressure, and we need to place it correctly. And the blood pressure should perform in the right arm of the patient after that the patient stay rested. So we need to let him stay in the supine position for at least 3 minutes. And we should take the position in a seated position. We should measure the blood pressure, and in a quiet environment. So we need to put him at least 3 minutes in a quiet environment before measuring his blood pressure. And sorry, I said in supine and seated position, the blood pressure should be measured in supine position. So not in seated position. It should be measured in pediatrics in a supine position. Okay. If the initial evaluation of hypertension, blood pressure measurements are obtained in both upper and lower extremities to detect possible presence of coarctation. So coarctation of the aorta is a narrowing in the aorta. So when we have a narrowing of the aorta, we'll have less blood that will reach the lower extremities. So we will have blood pressure difference between the upper extremities and the lower extremities. So we tend to have elevated blood pressure in the high and the upper extremities. So we have hypertension in the upper extremities, but we have low blood pressure in the lower extremity. And when we have this, we need to have a high degree of suspicion for aortic coarctation, because aortic coarctation is a pediatric disease and we need to suspect it early on. And at each visit, so at least we need to make 2 blood pressure measurements, should be obtained, separated by 2 minutes. And the values should be less than 5 millimeter mercury different. So we need to keep repeating them until we reach a stable value. So we put them on a chart, and we calculate the average values in order to have a blood pressure for the patient. As you can see here, so like we do on adults, but here the cuff has smaller size, and it has a smaller size and is a bit different than the one we use in adults. So here is the width and the length for newborns. The width of the cuff should be 4 centimeters and the length should be 8. And as we grow up in age, we increase it. So we need to have special material to measure blood pressure for young patient, and not use the same thing that we used to for adults. So a new diagnosis of hypertension should not be made until systolic and or diastolic blood pressure become above or equal to 130 to 80 millimeter mercury, as we said. So this is considered stage 1 hypertension, and we should confirm these measurements on 3 separated visits. So not just from one visit. If a patient comes with this blood pressure, we can't put the diagnosis of hypertension until we measure it on 3 separate visits. So we need 3 separate visits in order to confirm the diagnosis. So like in adults, we should inflate the cuff to the maximum, or to 20 to 30 millimeter above the anticipated systolic blood pressure, and then we need to deflate it slowly at a rate of 2 to 3 millimeter per heartbeat. So like we do in adults, we all know how to take the blood pressure. And the systolic blood pressure is equal to the pressure of which the brachial pulse can be first heard by auscultation. So when we hear the first pulse, when we are deflating, we hear the first pulse in the stethoscope. So this should be considered the systolic blood pressure. And we keep dropping the pressure by 2 to 3 millimeter mercury with every heartbeat, and until there's abrupt muffling of the sound, followed by the disappearance of the sound. So this is the diastolic blood pressure reading that we get. Sometimes we can use ambulatory blood pressure measurements. So we give the patient a machine that they put for 24 hours. It will be attached to the patient arm, and it will measure the blood pressure every 20 to 30 minutes. And at the end, it will give us an average blood pressure for the blood pressure and at the daytime and blood pressure at nighttime. And you always we need to have a lower blood pressure at night, because if the blood pressure doesn't drop at night, this is associated with the worsening of the prognosis of the hypertension, and it's considered an advanced stage. So we need to check for blood pressure dipping. We call it dipping, so drop of blood pressure at night as compared to daytime blood pressure. Okay. So we have 2 options. Either we measure 3 times the blood pressure in the clinic, so 3 separated visits, or we can put this machine, which is called ambulatory blood pressure measurement. It's the same thing that we do in adults. So we can use both ways in order to diagnose hypertension. And as you know, hypertension can be classified as primary or secondary. So it's the same thing in adults. So the primary hypertension is the most common. It's usually idiopathic without a confirmed cause. It's common in school-aged children. So especially in children that have positive family history of hypertension, they tend to always have parents with hypertension. They are most of the time overweight, obese, and mainly African American pediatric patients. They tend to have a more elevated blood pressure because African American have different genetics, especially in the field of hypertension. So same as adults, African Americans are more prone to hypertension and to cardiovascular diseases in general. So what are the risk factors for primary hypertension? We have the obesity, as we said. Obesity is a risk factor for all cardiovascular diseases, including hypertension. So boys are more commonly prone to have hypertension as compared to girls, and it was most common in African non-Hispanic, so African American patients, so Black patients, not all Blacks, the African American Blacks are more likely to develop hypertension, and young patients with a family history. So these are risk factors to develop primary hypertension at a young age. Okay. So secondary hypertension. So when you have another diseases like renal disease, we can have associated hypertension. So renal disease in young, the most common causes of renal disease are Henoch-Cholin-like purpura. It's a systemic disease that affects the skin and affects the kidney and can cause glomerulonephritis. So loss of protein, you will have loss of proteins in the kidneys, you will have massive loss of proteins in the kidney. This will lead to increased risk of thrombosis and will increase risk also to develop hypertension. And we have other anomalies like polycystic kidney disease and Wilms tumor. So polycystic kidney disease, like in adults, is a risk factor to develop hypertension. Endocrine disease like hyperthyroidism. So hyperthyroidism is a disease that accelerates the heart rate and causes vasoconstriction in the peripheral vessel. We have congenital adrenal hyperplasia, so we'll have increase in secretion of aldosterone, and aldosterone will cause increase in blood pressure. Diabetes, hypercalcemia. Hypercalcemia was also associated, we have hypercalcemia mainly in case of hyperparathyroidism. So the parathyroid gland is responsible of secreting PTH. PTH is an hormone that will act on the bones in order to break down the bones and cause increase in calcium blood levels. So cases of hyperparathyroidism can be found in children, and they can lead to hypercalcemia and to high blood pressure. Primary aldosteronism, as we said, so increase in aldosterone level. Pheochromocytoma is a disease responsible of secreting catecholamines and epinephrine, so we'll have increase in blood pressure, significant increase in the blood pressure associated with headache and tachycardia. So it's common and it's can be associated with other conditions as well. Vascular diseases like renal artery obstruction, renal artery stenosis will activate the renin system. So increasing in renin will cause increase in aldosterone, and we have sodium retention, and sodium retention will lead to increase in blood pressure. Coarctation of the aorta, as we said in the previous slide. So coarctation of the aorta will have difference in blood pressure between the upper arms and the lower extremities. So we'll have hypertension just in the upper limb. When you measure the blood pressure in the lower limb, we'll have normal or too low. We'll have usually a low blood pressure in the lower limb because we have decrease in the blood flow due to this narrowing of the aorta. So this is common in pediatric patients to have coarctation of the aorta, and the management of the coarctation is usually surgical management to try to deobstruct the aorta. Pharmacologic causes. So some patients take sympathomimetics drugs, stimulant drugs, corticosteroids. It's a very common cause of hypertension in pediatrics and in adults because it can cause volume retention and sodium retention. OCPs, so hormones, so hormone replacement therapy, cocaine, caffeine, nicotine. So all these things can cause elevated blood pressure. Psychological cause, so mental stress and anxiety, especially in school children, because as you know, there is a lot of bullying in schools and there's a lot of mental problems, anxiety. So this will increase the depression rate, and depression rate will cause more vasoconstriction. So we need to make school campaigns in order to look for any psychological distress in children. Other causes, rare causes like, as you said, neuroblastoma, tuberous sclerosis, and neurofibromatosis. These are rare diseases, but they can be found in children. So when we examine a pediatric patient with high blood pressure, we need to do the physical examination first in order to try to establish an etiology for the hypertension. Before doing an imaging or before doing anything, we just need to do the physical exam. So first of all, we need to check the BMI, if the patient is obese or not, because as we said, obesity is a risk factor for essential hypertension. So we don't have any organ dysfunction, you just have obesity. Obesity will promote high blood pressure, so we call it essential hypertension or primary hypertension. If we have growth retardation, for example, if a patient has 5 years of age, but he looks like a 2-year-old patient, we need to suspect growth retardation, and CKD, chronic kidney disease, can be associated with growth retardation and can cause elevated blood pressure because, as we said, renal disease in children is almost always associated with high blood pressure. So truncal obesity, when we see obesity, especially in the truncal area, so this we need to suspect Cushing syndrome. Cushing syndrome is a hypercortisolism, so we have excessive cortisol secretion, and cortisol secretion can come from the pituitary gland in the brain, so we can have a tumor in the pituitary gland secreting cortisol, or we can have an adrenal gland secreting excessive cortisol. Or we can have exogenous ingestion of corticosteroids, like is the case of corticosteroid medications. We need to check also the vital signs to look for tachycardia. If you see tachycardia, we need to think of hyperthyroidism, so increase in TSH secretion by the thyroid gland, increased secretion of T3, T4 by the thyroid gland, or we have catecholamine excess, like the case of pheochromocytoma, as we said. And we need to always measure blood pressure. When we see a patient with high blood pressure, we need to measure the blood pressure in the two extremities, so upper limbs and lower limbs. And if we see a difference of blood pressure, we need to suspect coarctation of the aorta. Sorry. Okay. So same thing, we need to look for the skin, because we said that some diseases can cause skin feature like neurofibromatosis. It can cause café au lait spots. It's a very typical feature for this disease, and it's associated with hypertension. Okay. Okay, so sometimes we can palpate the abdomen as well. We can palpate the kidneys, and if we see masses in the kidney areas, so we need to suspect polycystic kidney disease or a renal tumor like the Wilms tumor or abdominal, which is an abdominal tumor. So polycystic kidney disease can be seen on physical examination by palpating the abdomen. So we can detect that we have masses, and in that case, we need to order an imaging. So we either do an echo, so an abdominal ultrasound, or an abdominal CT scan, in order to evaluate this mass that we detected on physical examination. So now I will show you a case. It's a case of a 16-year-old girl. She has a negative significant family history. She just have, except for hypertension, in both her grandparents. So grandparents have hypertension, but at an advanced stage. There is no high blood pressure in the family at a young age. Even her two parents don't have hypertension. Her past surgical history is consistent for an adenoidectomy performed at the age of 4 years. So this has nothing to do with high blood pressure. And her past medical history, so at the age of 3, she developed a picture of acute encephalitis. So she had an infection of the cover of the brain, so the encephalum. And this was considered, they didn't have a diagnosis, they considered, so it's either infectious or autoimmune cause. And they did an MRI for the brain at that time, and after 1 year, it showed regression of the right cerebellar hypersignaling noted previously. So encephalitis had improved, so it's her own past history. So at the age of 6, she had a lab test which showed severe hypokalemia, so potassium level of 1.7 millimole per liter, which is very low. She did these blood tests because she had bilateral lower limb cramps. So at the age of 6, with bilateral lower limb cramps, they did a lab test and it showed hypokalemia. And because she had age of above 3, as we said, it's indicated to measure her blood pressure once per year. So they measured the blood pressure and she had a systolic blood pressure of 150 millimeter per mercury. So she was transferred to another hospital because of lack of place in this hospital, and they repeated the labs. It showed also a potassium level of 1.9. So she has persisting hypokalemia. And she has a bit elevated bicarbonate, so it's a bit of metabolic alkalosis. So 27 bicarb is on the upper limit. So it's a beginning of metabolic alkalosis associated with severe hypokalemia. So what are the possible diagnoses? So always, when we see hypokalemia in pediatrics and in adults associated with hypertension, we need to suspect primary hyperaldosteronism. So primary hyperaldosteronism, it's either a tumor of the adrenal gland that will secrete aldosterone, and as we said, aldosterone is responsible for sodium reabsorption from the urine. And it's also responsible for eliminating potassium in the urine. So we lose potassium and we will gain sodium. So we tend to have a bit higher level of sodium, but they are usually in the normal range, but in the upper limit. But we'll have lower level of potassium always. So we'll have severely depressed potassium level. So hypertension plus hypokalemia add metabolic alkalosis, but not always we see it. It's primary aldosteronism until proven otherwise. So in that case, we need to do a dosage of the renin to aldosterone ratio. And they did labs. You can see that she had an elevated aldosterone level and a suppressed renal level, because when aldosterone increase, we'll have a decrease in renin level. It's normal. It's a negative feedback in order to stop the renin, in order to prevent further increase in aldosterone, because we said in order to produce aldosterone, we need the renin. And when the aldosterone increases a lot, the body will react and will drop the renin production in order to try to decrease the aldosterone production. But in case of primary hyperaldosteronism, this mechanism will not work because we have a tumor or a gland hyperplasia. So it's either a tumor or a gland that is functioning excessively, that is causing excessive aldosterone production, regardless of renin production. So it's not having to do with renin production. So they did an renal ultrasound for these patients, and they show that she has a normal Doppler renal ultrasound. The kidneys had a size of 8.4 centimeters. They did a cardiac ultrasound as well. It showed a left ventricular hypertrophy, because we know that high blood pressure can cause left ventricular hypertrophy. And she had bicuspid aortic valve. Normally, the aortic valve is tricuspid. She had a bicuspid aortic valve. They did an abdominal MRI in order to diagnose hyperaldosteronism. They found no adrenal tumor. So if we didn't find a tumor, so it's not an adrenal tumor, it's usually an adrenal hyperplasia. So the adrenal gland is secreting more aldosterone than usual. So it's not a tumor in that case. They did also a cerebral MR to check for the previous encephalitis evolution, and they find that we have same as previous findings, so we don't have increase in her encephalitis that was previously described in the previous years. So the confirmed diagnosis is a confirmed primary idiopathic hyperaldosteronism. So how to treat it? We need to try to block the aldosterone. So we use a drug called aldactone or spironolactone, which is an aldosterone blocker. And we use a drug which is a calcium channel blocker, nifedipine. It's a calcium channel blocker in order to drop her blood pressure. And for sure, we need to supplement the patient by potassium supplementation. For sure, we need to start supplementation by IV potassium in the hospital, because potassium of 1.7 is an indication to hospitalize the patient because of the risk of the cardiac arrhythmias that can be caused by this very low potassium level. And 1 year later, the patient readmitted for the same things, hyperkalemia and uncontrolled hypertension. And she was also found to have very high aldosterone concentration of 2,237 picogram per milliliter, with renin less than 2, so low renin level. And they repeated the cardiac ultrasound, so same thing, moderate left ventricular hypertrophy, and they stopped nifedipine and they started her amlodipine. Amlodipine is another calcium channel blocker. Sometimes it has better effects on treating high blood pressure, and they increase the aldactone dose. Or aldactone, we said it's a spironolactone medication. It's a potassium-sparing diuretic. It will act on blocking the aldactone pathway and increasing the potassium level. So she traveled to Paris at the age of 10 to another hospital where they did repeated the abdominal MR, and the abdominal MRI done and showed no involved adrenal hyperplasia or difference in both glands. So sometimes we don't see it on the gland. The hyperplasia, like sometimes you need to, you can see a normal adrenal gland, but the adrenal gland is secreting excessive amount of the aldactone. So in that case, we can do something called adrenal vein sampling. So we introduce a catheter in the adrenal vein, and we measure in that vein the amount of aldactone secreted, and in this way we diagnose for her the aldactone hypersecretion by the adrenal gland. So they did this, and she had high level of aldactone in her adrenal veins. So they confirmed the diagnosis, and they kept her on the same treatment, and she improved by increasing the dose of spironolactone and increasing the dose of amlodipine, and she had almost normal blood pressure in the next few years after follow-up. Okay. So hypertension is widely reported complication of immobilization. So what can cause immobilization? For example, if a pediatric patient have fractures, so he won't be able to move, especially fracture of the extremities. Burns as well can cause it. Illnesses, other chronic illnesses can cause it and can cause depression, and depression will cause a decrease in mobilization for the patients. So why immobilization will cause high blood pressure? Sometimes immobilization will cause increase in calcium level due to immobilization, and it will cause increase in sympathetic activity. So we'll have secretion increase of epinephrine and norepinephrine that are responsible for elevating the blood pressure. So hypertension is reported within 7 to 10 days of hospitalization, and up of half children admitted for burns. So burns is associated with a lot of the incidence of hypertension, and is more common in patients with greater than 20% body surface area burns, because burns are also associated with increase in calcium level and increase in immobilization. So we'll have an increase in the blood pressure. We also can have some medications like stimulants that we use in children's, like the amphetamine, which is called dexedrine and Adderall, and methylphenidate. So the commercial name it's Ritalin and Concerta. These drugs are used for attention deficit or attention deficit hyperactivity disorder, so ADHD, narcolepsy, and depression unresponsive to other medical therapies. So these drugs can induce increase in blood pressure as a side effect. So we need to make sure of all the side effects of the patients of the medications, especially in pediatrics. So to treat hypertension in pediatrics patients, we have two approaches. We have the pharmacologic approach and we have the non-pharmacologic approach. So pediatric hypertension is associated, if left untreated, with increased risk of cardiovascular disease and increased risk of progression to CKD, chronic kidney disease, and end-stage renal disease in adult life. So non-pharmacologic approach, like adults, we need to have weight reduction, we need to drop the BMI, we need to perform regular exercise. So daily exercise is possible for 30 minutes to 60 minutes per day, or five days a week. We need to do dietary modifications. So we need to do salt restrictions, the most important diet modification, and low-fat diet for sure. And we need to reduce other cardiovascular disease risk factors such as preventing or treating dyslipidemia. So every patient with hypertension, we need to check his lipid levels So if we have dyslipidemia, we need to treat. We need to avoid smoking, mainly in the pediatric patients. We need to avoid smoking, avoid alcohol, avoid caffeine, and energy drinks. So if we implement all these 4 points in pediatric patients, we can have resolution of elevated blood pressure in 44% of participants with elevated blood pressure measurements. So it's a lot more than in adults, because in children with hypertension, they don't have a lot of vessel stiffness, and they are in an early stage of their disease. So if we treat early, we can reverse the disease progression and have normal blood pressure level, not requiring medications. But if we need to add medications, so if the lifestyle modification doesn't work, we need to start them on medications. So we need to treat symptomatic patients or patients with stage 2 hypertension. So stage 2, we said it's blood pressure above 140 millimeter mercury systolic, or stage 1 hypertension that despite lifestyle modification for 6 months. So easier stage 2, we treat directly. We don't wait for lifestyle modification. And stage 1, we can try lifestyle modification. If it doesn't work after 6 months, we need to treat. Or if we do a cardiac ultrasound and we find left ventricular hypertrophy, so then it's an absolute indication to treat. Because if we have left ventricular hypertrophy, it means that the high blood pressure is present for a lot of more years. So the hypertension was present since many years. Because to have left ventricular hypertrophy, it can't be an acute presentation. It's a chronic high blood pressure that will cause left ventricular hypertrophy. So we treat these conditions by pharmacologic therapy and not just lifestyle modifications. Okay, so what are the therapeutic options? We have the antihypertensive drugs, like we use in adults, the same medications, we can use them in adults, but we need to be more careful for the side effects. We have the angiotensin converting enzyme inhibitors, the angiotensin receptor blockers, the thiazide diuretics, the calcium channel blockers, and the beta blockers. So the first line drug should be combined efficacy with minimum side effects. So we need to start with a low dose to avoid the side effect. We don't have to start with a high dose directly. And if we don't achieve a blood pressure target, we can add a second drug. So we can combine 2 drugs in order to achieve our blood pressure goal. So it's better to start with a calcium channel blocker, because calcium channel blockers tend to have less side effects as angiotensin receptor inhibitor and as angiotensin converting enzyme inhibitor or angiotensin receptor blockers. Calcium channel blockers tend to vasodilate vessels, so there's no major side effects with calcium channel blockers. Sometimes we can see reflex tachycardia as a reflex to vasodilation, but ACE inhibitors and angiotensin receptor blockers tend to have a lot of side effects, like increase in kidney function, so increase in creatinine level, and impairment and increase in potassium level. So we might have hyperkalemia. So it's better to start with the CCB in children. Then if it doesn't work with the CCB, we can add an ACE inhibitor or an ARB. Sometimes if we have CKD, we said that ACE inhibitor and ARB can increase kidney function, but also they are protective if we have already established CKD. So they decrease proteinuria and they are effective. So if patient has a CKD associated with high blood pressure, then it's better to start him directly with ACE inhibitor or ARB therapy. And in diabetes associated with hypertension as well, ACE inhibitors and ARB are helpful in order to delay the development of diabetic nephropathy. So they decrease proteinuria, and if they decrease proteinuria and albuminuria, then we will have a decrease in the risk of diabetic nephropathy. And diabetic nephropathy will lead to dialysis on the long term. So if a pediatric patient develops diabetic nephropathy, for sure, this patient will have a dialysis and the need of kidney transplant at an early age. So thank you. We finished this second lecture about pediatric prevention. If you have any questions, please let me know.
Thank you, Dr. Antoine. Okay, we will take around 10 minutes of break, and we will be back at 10 past 10.
Okay.
Thank you.
Thank you.
Cost-effective manner. One way is to provide patients with a patient satisfaction survey. So surveys give patients the opportunity to provide anonymous feedback that can be used to make improvement. So you could also enlist members of your team to have brief, casual conversation with patients during their clinic visit. So anyone in the practice can get a pulse on patient experiences by simply asking patient, how was your visit today, for example, or do you have any feedback you would like to provide to us? This question can be asked by staff at checkout by a medical assistant as they escort the patient out of the exam. Of the visit, or by one in the practice that finds themselves sharing in the room or in the space. So also they can review the result. You can review the results of the current state assessment to identify them and the trends stakeholders, and you can highlight also when discussing the program direction. So the feedback collected could help create guiding principles for the program and serve as a catalyst for change. What should be included on the patient satisfaction survey? So practice can utilize existing surveys or create and customize a survey based on their practice needs. So some common themes on patient satisfaction surveys include access, including teamwork, communication, front desk friendliness, and office cleanliness, and billing. So you could also consider asking, for example, we can ask patient, would you recommend the practice to a friend? Or this question established likelihood to recommend. So which is a loyalty indicator and an indirect measures of patient experience. So many surveys aim to understand how patients feel about specific components of the practice, and then how likely they are to return and refer others to the practice or to the organization or to the hospital. Moving to the step 2, define your North Star. So your North Star is what your practice will strive towards and guides your program's purpose and structure. So when define your North Star, you make sure you gather and discuss different team members, so patient and caregiver perspectives. So take your time as a team to characterize the ideal patient experience and outline goals for the program. Consider how you will engage other physicians, staff, patients, families, and patient's loved ones. So what are some examples of North Stars? So your North Stars will unite your practice around a common goal and support the development of your patient experience program. So these North Stars may be defined by your organization's mission or vision statement. For example, patients first, or another statement like healthcare that cares, or for example, advancing health together. So it's a like slogan, like a statement. Let's see about the step 3. So the step 3, it's about engage key stakeholders in experience design. So culture is critical here in creating a sustainable patient experience program. To build a relationship-centered program, you need to have a culture that encompasses teamwork, integration, good communication, and an environment supportive of continuous learning. So here we can involve all clinical care team members. Also administrative leadership, front desk, scheduling staff, physician, and perhaps most importantly, your patient in program creation. Share the results of your assessment of the current state of the patient experience and discuss reaction and trends. We can do also a brainstorming session to come up with ideas for your patient experience platform. So I can tell you here to take the opportunity to ask employees about the challenges they face in daily operation to identify areas where additional training could be useful. You can also include patient in the design process by holding like a focus group to evaluate ideas. Here we have 2 questions. Why is it so important to include stakeholder at all levels in experience design? And the second question, should we benchmark against other practices or organization in our area to help set the strategy? So the first question, why is it so important to include stakeholder at all levels in experience design? There is not one ideal patient experience program. So there's a different practices and patients will have varying preferences and expectations. Including stakeholders from all levels and areas in your practice can help the organization or can help you uncover valuable and sometimes surprising insights. For example, a team member who worked in the front desk area may notice that there is inadequate seating on busy clinic days, or that the waiting area music is too loud, for example. There are things that care team members may notice in passing without recognizing the impact that they are having on a patient's experience. The second question, should we benchmark against other practices or organizations in our area to help set strategies? Here, while you may choose to look at what your competitors are doing well and emulate best practices, this should not be the major driver for creating a patient experience program. So vendors exist that enable benchmarking, but if your efforts are grounded in your local culture and patient need, you are on the right track. Moving to the step 4, develop and implement your patient experience strategy. To ensure success, start small and pick an option that is sustainable and scalable for your practice. Here are some ideas. We have some sub-steps, if you want, here in step 4. It's step A to E. So step A, it's to consider creating a patient and family advisory council. This is very important. This patient and family advisory council, PFAC, is a partnership between patients, families, caregivers, and members of the care team that encourages honest feedback and constructive criticism to make the practice better. So it can ensure the voice of the consumer and is integrated into prioritization of decisions. Your practice makes related to change that will affect also the patient community. Moving to the step B, institute regular leadership rounding, where leaders are out in the clinic speaking directly with patients, with families, and with caregiver about their experience in the practice. So rounding enables the clinic leadership to connect with patients in real time to gain a deeper understanding of tactics to strengthen care. This approach can also provide opportunities for immediate service recovery and feedback for staff and physicians. So you could assign a team of leaders to specific clinics or request that the manager, administrator, or lead physician engage with patient in their own clinic. As per the step C, make improving employee engagement a priority. So employee engagement is imperative to a successful patient experience program. So it's important to understand what drives employees and why they come to work each day. Consider conducting an employee engagement survey to better understand how staff members feel about their work environment. So we have to engage also the employees. So communication, teamwork, safety, confidence in management, and the ability to provide quality care are the key topics to cover in an employee engagement survey. So as per the step D, it's implement service excellence training for employees at all levels. So this the service excellence is more than a friendly face. So it requires a core set of standards that yield a framework for training patients with courtesy and respect while offering the highest quality of care. So such training teaches staff how to effectively handle patient concerns in real time, as well as how to respond in a way that demonstrates empathy to the patient's concern. So like acknowledge, introduce, duration, explanation, and thank you, and communicate with heart are examples of common service excellence training tools that help teams establish powerful communication framework for staff to use it with patients. Step E, it's teach effective and empathic communication. The strengths of the relationship between a patient and their physician and other care providers significantly impact the patient experience. So a strong relationship is founded on effective communication. So initiate conversation with clinicians to understand how they are currently introducing the computer, working with patient on agenda, setting and other aspects of the patient encounter to understand any challenge they are facing in effectively. So find avenues to maximize the communication. So we should maximize communication and peer training. So practice listening with empathy, teach back, and other methods to foster strong communication. So here we have a questions, which is what are some common practice challenges and where do we start? So you should use your patient experience survey and feedback as a guide. So here is some example. I will tell you some example about how or initiative how to improve patient experience. So for example, improve lab results reporting. Consider using your patient portal to automatically send a note about results being available to view along with your nurse's contact information in case the patient has questions. Another example, reduce patient frustration with wait time, which is very important. So communicate delays to patients in a timely manner. Identify internal solution to chronic bottlenecks and work with your team to address them. So some practices have a manager come out with coffee or vouchers when wait time are abnormally long. Another example, like for reduce patient dissatisfaction with billing and insurance-related issues, etc. So it's unlikely that you will be able to eliminate all billing and insurance-related complaints for sure, but training staff on basic insurance information and office billing practice can help them answer questions from patients. So they will know how to answer the question concerning billing, insurance, etc. Another example, implement pre-registration. Collecting important demographic and insurance information ahead of the patient's appointment can significantly expedite the check-in process and eliminate delays. Moving to step 5, analyze feedback and determine impact. So you may choose to repeat patient satisfaction surveys as a part of your ongoing program strategy. Many surveys use similar measures that you can trend over time. It's likely that you won't be able to quantify all parts of your patient experience program. So quantitative input can be just as valuable. So look for trends in the comment section of your patient surveys. If you started a patient at Family Advisor Council, as we said before, ask how it's going. Is meeting attendance strong? Are patients engaged and happy, etc.? Moving to this question here, should I give group feedback to care team members other than the physician? The answer is yes. It is surprising how many practices do not share feedback with their clinicians or teams. By sharing information, you create an environment of continuous quality improvement to keep employees engaged. So communication, it's really very important, and sharing information between the team. So during team meetings, you can use the results and patient comments to identify opportunities for improvement and highlight practice and staff strengths. So other ways to share this information or this feedbacks, you can share it by email or daily huddles or display visual management boards in a common area. Okay, moving to the step 6, the last step, recognize accomplishment and improve over time. It's building a patient experience program can be a challenging process, so your team will continue to stay engaged if they feel the program has value. So make the program a key discussion topic in team meeting. So continue to ask for employee feedback and suggestion on ways to improve and enhance the program. Regularly share any results and positive affirmation gleaned from surveys, and share patient suggestion and stories from the PFAC, the program family, or leadership rounding. Here, physicians and management should lead by example or by participating in the various patient experience initiatives within the practice. There is something I would like to tell you here about the celebrate the team. It's important to celebrate the team members who are shining in this effort. So share uplifting or positive patient narratives, invite a patient to speak and present the highlights of mystery shopping to raise an awareness of how the practice is moving towards is North Star. So when here we can ask, when should we consider adding to our patient experience program? Once you've implemented your first patient experience strategy and your staff and patients seem to be responding positively, you could consider adding another component. You can change or you can add another component on your program. So there really is no roadmap, which is both the joy and pain of improving the patient experience. So the best approach is to work closely with patients and families to guide the evolution of this program. Okay. So anonymous patients comment about their experience. This is important. I will share with you this anonymous patient comment, for example, just for an example. So I have had, so the patient said, I have had and continue to have excellent service from Dr. Ala staff and excellent professional and caring medical care from Dr. Ala herself. So I'm retired from the army and I have had many experiences with medical doctors, civilian and military, national and international. So Dr. Ala is by far one of the most knowledgeable, professional and personally caring physicians I have encountered. She is never hurried. She listens and hears my question and concern with compassion. Most important to me, she gives me the best professional instruction and guidance and leaves me with the confidence I need to take better and better care of myself. So he said also, Dr. Ala is a stellar example of what physicians should be. She is pragmatic about her decisions to affect my healthcare courses of actions. So I have and will continue to recommend her to professional and community associates and friends. So this is an example of a patient comment, a positive patient comment about the health professional, the doctor, and the institution. Okay, a take-home message here for this part. It's building a patient experience program is a team effort that requires dedication along with an openness and desire for change. The voices of patients and their loved ones and families can provide valuable input on what a practice is doing effectively and where improvement opportunities exist throughout the patient journey. Using this information and partnering with patients allows practices and organizations to design services that transform clinical care, enhance patient loyalty, and most importantly, bring more meaning and joy to patients and caregivers. How you attract and retain patients. So patients have greater access to healthcare and providers of their choice, ensuring a positive patient experience can help you continue to be their provider of choice, not just the provider of last resort. So it will help you also to attract and retain patients. So patients have higher expectation than they ever have. So meeting or exceeding those expectations is a must. Allow me here to talk about quality care for provider. We have the safe, effective, patient-centered, timely, efficient, and equitable. So the provider perspective, according to the Institute of Medicine, is safe, first of all. So safe is avoid injuries to patient. For example, the reason to monitor blood pressure for patient using combined hormonal contraception. So it's kind of safety for patients. So the second one is the effective, much care to science. For example, offering a full range of methods, including because they are effective. patient-centered, like honor the individual and respect choice, the hallmark of title. So timely, as per the timely, so reduce wait time and provide services to patients when they are needed, like being able to get an appointment when needed. The next one is the efficient, reduce unneeded tasks, services, etc. So making the best use of resources and staff time, and being equitable, close racial and ethnic gaps in health status. So Title X is trying by its very existence to close gaps in healthy equity. So patient safety, the measures that should be taken by organization to assure the safety of the patient. Patient safety goal, improve communication, prevent wrong site, wrong procedure on wrong patient, prevent the risk of hospital-acquired infection, prevent harm resulting from patient's fall. And second, error prevention and just culture, codes, fire, and medical equipment and utilities. International patient safety, the goal number one is to identify patient correctly, name and medical record number, know your patient and family, and we should know also why admitted, and the history, diagnosis, and allergies. It's very important to know all of this. When you communicate information with staff about your patient, identify them by name and by MRN, the medical record number. Prior to giving medication, verify patient's name and medical record number, the both name and medical record number on the armband against the medication administration record, and ask the patient to say his or to say her full name. Do not call their name. Ask her to say or ask him to say the full name. Don't call him by his name. The goal number two is to improve effective communication. When receiving phone order from a physician, for example, identify patient correctly with the physician. So make sure that you are talking about the same patient and you are understanding what the physician is saying. So write down the phone order on the physician's order sheet and the patient's file, the medical record. Read back the order to the physician. We should read back the order. So write the order and read it back. If you need another nurse to double check the order with you, the second nurse must follow the same process of listening and writing and reading back the order for sure. So when you read back a medication dose, for example, 50 milligram, read it back as 50, 50. So make sure that you ask the physician about, you don't tell him 50 because sometimes they can hear 15. Or maybe he can say 15, you hear it 50. So make sure that you say 50 or 15 for 15, for example. Improve effective communication. When receiving critical lab result, identify patients correctly. So write down the result, sodium 150, read it back. So read back the order to the lab technician to be sure. And when you read it back, for example, 150, read it back as 150. For the same reason that sometimes you can hear it 115 and it's 150 and it can change everything. So if you need to write the ID number of the technician, give him or her your ID number also. And the most important thing also to inform the physician. The International Patient Safety Goal 3, high alert medications. So high alert medications are medications that bear a high risk of causing significant patient harm if they are not used correctly, especially with the cardiovascular disease. For with all the patients, but with the cardiovascular disease also. So two staff will double check the full 7 rights of medication independently prior to administration of this medication. Okay, everything is good? Okay, to continue with the goal number 4, prevent wrong site, wrong procedure, and wrong patient. Make sure site marking is done on patients prior to invasive procedures. Follow the policy and check out the forms to be filled out prior to sending patient to procedure. And have the timeout, so stop and check. This is a timeout. Don't be in a rush. Stop and check all the necessary documents just before the procedure. Okay, moving to the international patient safety goal number 5, it's to prevent the risk of hospital-acquired infections. So washing hand with an antimicrobial agent and water for minimum 40 seconds up to 60 seconds. Or using alcohol-based hand rub 20 to 30 seconds. Hands may need to be washed after 5 to 10 applications of alcohol-based hand rub. Alcohol-based hand gel should not be used when the hands are visibly soiled or if the patient has Clostridium difficile infection. So beware, clean hands care. The 6th goal is to prevent harm resulting from patients' fall. All patients are assessed for the risk of falls using the fall risk assessment, reassessment tool, and admission weekly and more frequently when patient conditions change. So we should always do the assessment and reassessment when we feel or when we see that the conditions of the patient change. For example, post-falls, post-procedures, transfers to general units 4 hours, for example, or critical care units, change in medication regime that can affect level consciousness, narcotic, antihypertensive, hypoglycemic, chemotherapy, diuretic, and laxative, for example. So document the risk of assessment and take full precaution as per your protocol. Okay, we're done with this international patient safety. There is a 7. We have the 7 rights to the safety culture. So the 7 rights, starting with the right of patient or right individual, and right medication, right dose, right time, right road, right documentation, and right indication or response. Starting with the right patient, so making sure that you have the right individual is obviously a very important step in medication administration. So the standard is to check with at least 2 other sources that you have the correct person before administering medication. The most experienced of nurses can make a mistake if she's tired or if overworked or managing several patients at once. So despite your level of experience, you should always verify that you are giving the right person the right medication. Second, the right medication. So it goes without saying the ensuring that you have the right medication is paramount for a variety of reasons. So different patients can have different medical allergies, adverse reaction, and unexpected symptoms that could lead to catastrophic results. So read the label of the medication, triple check the patient's charts, and make sure you are administering the correct medication for that patient. The third right is the right dose. The right dose is incredibly important as well, as the wrong dose could lead to overdosing a patient and possibly harming them. So the patient's correct dose should be noted in their chart. and you should also know the form in which they should be receiving medication. So are they taking pills, receiving medication through IV, or swallowing liquids? These methods all require various doses. Moving to the right number 4, the right time. Many medications have a specific time that they need to be administered, either due to the patient's other medication or around their meals. So not all medication require a specific time, but it's your responsibility to know which ones do and which ones don't. So every time that medication is given to a patient, it should be recorded so that anyone treating them is aware of when medication was last administered. Moving to the right route. Route in this case refer to where and how the medication is given to a patient. While most medication are taken orally, this is not always the case, as you know. So the notes surrounding the way that medication should be administered and are important to keep communication clear as nurse shift change or another or others administer medication. So medication can be given in several ways, including rectally, vaginally, through the skin, in the eyes, in the ears, in the lungs, etc. So this leaves a lot of room for error if not correctly communicated. So we should be sure about the route, about the right route. The sixth one is the right documentation. So it's the sole responsibility of the person administering the medication to properly document the administration. Without proper documentation, communication can get lost between medical professionals. Always double check your document and make sure that all details are present and correct. The last one is the right response or right indication. So is the response that the patient has to the medication administered. Anytime that a patient is given medication, the response should be recorded to make sure that it's known to all treating the patient. Additionally, the level to which the medication helps the patient should be recorded to keep track of what medication is working and what isn't working. Okay. Moving to the quality according to the patient. So what the patient gets versus what they expect. So on the other hand, a patient defines quality by whether their expectations are met so that they get what they expected. So get equal expect equal average experience. So if a patient gets what they are expecting, that's good and usually indicates an average experience. So we hope they will feel satisfied when they leave. But is this enough to keep them coming back? Exceeding their expectation will result in a positive experience. So not only are they highly likely to come back, but they are also likely tell their friends and family about your hospital or your organization. Okay. What influences patient experience? So the patient experience are influenced by the system, the environment, the interaction, and the care. Talking about the environment includes things like location, cleanliness, comfort, etc. So the patient experience toolkit includes easy to use assessment that you can complete with staff. So the two features that help you look at your facilities and your website through the patient eyes. So it's important to know what the patient think about the environment. So if it's clean, if it's comfort, etc. Talking Talking about the interactions now, it includes friendliness, cultural appropriateness of services, use of inclusive and affirming language from when they call to make an appointment to when they check out. So positive interaction are driven by a handful of interpersonal skills. So everyone has room for improvement and everyone can learn to improve. So making a welcoming statement, using friendly words and tone of voice, for example, demonstrating empathy, putting language in the positive, and offering also always offering options. Okay. Talking about the system, so it's the influence of the system on patient experience. So system include clinic hours, staffing model, the appointment system, and clinic flow and wait time. So how patient-centered are your system? What does you should ask yourself, how patient-centered are my system, and what does my appointment system look like? How convenient is it to even make the appointment? So more and more services have online scheduling, and people are getting used to it. So this is an example of something transitioning from a delighter to a should have. So always ask, how are you doing reminders? Sending a quick text reminder is easy and helpful to your patient. So ask yourself about the wait time. Wait time is often the most common complaint of the patient. So try to reduce the wait time. Talking about so the patient satisfaction. So last one is the care. So patient experience is also impacted by the range of services and quality of care. So look the quality and recommendation to ensure you are providing quality family planning services. So how does teamwork change culture? So change your culture one behavior at a time. So change reaction, change performance, produce better outcome, improve efficiency, improve safety, increase joy. So it's important. So the joy at work. So patient satisfaction, how the patient felt about different aspects of their visit, what did or didn't happen. So assessing patient safety, assessing patient experience. So the question are patient satisfaction versus experience. So at high level, the two are used interchangeably in terms of assessment. However, there is a bit of a difference. So patient satisfaction is subjective. On a scale, for example, 1 to 5, how satisfied were you? Patient satisfaction includes asking how the patient feels about different aspects of their visit. Patient experience is more objective. It's about the measuring things that did and did not happen during a visit. So the patient satisfaction is subjective. The patient experience is more objective. So we can ask things we know of patient value and things we know have an impact on clinical outcomes. Did the patient get the methods they wanted? How many minutes did they have to wait? Did the provider make a welcoming statement? Things that can be observed or measured. Assessment patient safety. It could be a paper, an electronic survey, or mobile survey, and always should respect anonymity and explain why and we should always explain why we are conducting a survey and what is the value of the patient answers. So survey are the most common way, as you know, that to assess patient experience and satisfaction. So here is a few tips if you want. If you are collecting surveys from patients, don't ask them to hand their completed survey when they complete the survey. Don't ask them to hand this to the person at the front desk, for example, or at the checkout. So ask them to give you back the survey. Talk to your staff about how this is actually happening and what they say to patients when they give them the survey. So the staff should also know how to explain. Tell your patients why you are doing the survey, and you will get more honest answer for sure. Oops, okay. Here is ideas to improve patient experience. So create a helpful online presence. Your online presence, including your healthcare website and local directory profile, is the way to make a great first impression with prospective patients. So your website is your online home base and serve as a reflection of your practices overall brand. So to help a patient understand what to expect from your practice, make sure you are offering clear, consistent information on your website page. Offering online scheduling. So this is important, that give patients the freedom and convenience to book appointments online with your practice. Send appointment to confirmation and reminders. So patients are busy usually, so help them stay in communication with your practice with appointment confirmation and reminder. Not only do automated reminder let patients know you value their time, but they also help you reduce costly no-shows. Make paperwork available on your website, so cut down on the tedious tasks for patients when they arrive in your waiting room by giving them the option to view, print, and fill out intake forms before their visit. Patients can here fill out the necessary paperwork when it's convenient for them and avoid completing it in a rush before an appointment. Instruct front office staff to be friendly and helpful. So providing a great experience during a patient's visit is essential to keep patients coming back. So a warm, welcoming attitude from the front office staff helps set the tone from the moment they walk in the door. Simple gesture like saying hello, smiling, being friendly during the check-in process, or often all it takes to start the visit of right. Ensure the waiting room is clean and comfortable, so make your waiting room a place that's enjoyable for patients before their appointment. Keep wait times to a minimum, so a bit of a wait is understandable, but patients become frustrated when they feel like you are not respecting their schedule with excessive wait time. Follow-up appointment with a survey. So after the visit, use thoughtful touch points to interact with patients to show them you value their feedback. Sending automated patient satisfaction survey via text or email will yield higher engagement. So since patients aren't as likely to submit a survey on their own. Promptly respond to online feedback. So responding to feedback, both good and bad. So it's just as important as collecting feedback from patients. Thoughtful responses foster trust with patients and show you care about their experience with your healthcare practice. Also about share helpful content on social media and a blog. So creating and sharing content on your blog and social media profiles is a great way to provide valuable healthcare information and increase patient satisfaction. So consider what patients want to know about the treatments and services you offer. Stay in touch with patients through their inbox. Email is another way to have thoughtful communication with patients, likely through a regular newsletter or promotional offers. Here, allow me to talk about 5 ways to satisfy patient in less time. First one is to find out about your patient's need first. So it may not be the most clinically significant issue, but finding out what your patient considers a priority is important. So you will save time because your patient can be a better listener after his concerns have been addressed. And here you may avoid the all too common request to restart the visit when the patient forgets to introduce his concern, but then recalls it as he is walking out the door. Help patient create a relationship with your support staff. Do you have patients whose mantra seems to be, I only talk with the doctor? So perhaps some patients say that I will only talk with the doctor. So perhaps it's because they haven't created a relationship with anyone else in your organization. So a few no-cost, no-time tips to begin building this relationship. For example, everyone should wear a name tag at chest or collar level. So you and your staff should refer to one other by name so that patients begin to learn names. See your receptionist to book an appointment in 6 weeks should be replaced with, for example, the name, our reception, etc. Then minimize interruptions. Those now, where, and where we. This is a conversation always result in longer visits. Consider reserving 10 minutes of each hour for telephone calls that requires interruption as your regular interrupts become accustomed to your practice. So they will begin to call you or return your phone call during your call time, etc. The first one is to be prepared. Be prepared, it's the time to find out that you don't have the patient's lab test result. It's not during the visit. So have a system to review the record ahead of time so that missing information can be obtained prior to the patient visit. The last one is put it in writing. So for your patient who read, putting the simplest of instruction in writing enhance the likelihood that they will follow through on your device. So your advice. So and you and your staff will save the time spent on post-visit telephone calls. Example: what did Dr. M, for example, tell my husband he was supposed to do? So moving to the strategy of communication with patient, introduce yourself and your role to each encounter. Try to determine the need behind repeated question or statement. Let your patient know that you are changing the subject. Now let's talk about, for example, you said, now let's talk about something else. So, and don't interrupt your patient, let him talk and express himself. Avoid figurative terms and that patient may interpret literally. For example, we're ready to take you to the floor now. So it's not really a good sentence, so avoid it. Align your facial expression and your message. Don't frown as you say your daughters come to visit, unless that's a big thing, of course. Avoid quick movement that may threaten or upset your patient. Don't patronize. Understand and acknowledge frustration. Use your patient's name. Use appropriate touch to gain your patient's attention. Face your patient when you are speaking to him. You can start to anyone when your first words are from behind the person. So face your patient when you are speaking to him. Ask your patient to do one thing at a time, as opposite to 2 or 3 things. Don't say, take off your shoes and shirt and then sit on the examining table. So don't ask many things to do, one by one. So thank your patient for talking with you. How to inspire trust. Keep your promises and use appropriate touch put yourself in your patient place, protect patient confidentiality, provide orientation for new patients, and find out what your patient needs first, and be conspicuously obvious about following standard precaution. How to encourage patient follow-up? This is very important. Follow-up is the act of making contact with a patient or caregiver at a later specified date to check on the patient's progress since his last appointment. So appropriate follow-up can help you to identify misunderstanding and answer questions, or make further assessments and adjust treatment. It helps to promote a good working relationship between you and your patients. So as an action, decide on the reason for follow-up. First of all, for example, you can follow up to monitor health, for example, or to reinforce knowledge and action plans, or you can follow up to confirm medicine regimen, or to schedule appointment, or to verify follow-through or referrals, and share lab results. You can ask patient to record information. It's important to ask him to record the information. An excellent way to monitor health is to have patient track key clinical values and share that information with you between visits. So for routine monitoring, example, blood sugar, blood pressure, weight, etc., patient can record their values. So this can be done using simple forms. So the follow-up instruction form, for example, is an example of a monitoring instruction sheet for a patient with diabetes, or to monitor treatment goals and to monitor blood sugar levels. Instruction to patients should include also directions to contact the practice when their clinical values are of concern. Blood pressure, for example, above 140/90. So, or for example, weight gain of more than 2 to 3 pounds in a day for heart failure patient, for example. So be sure to thank patients for recording this information, highlighting how helpful it is, and providing clinical feedback. Example, it looks like you are doing a good job of keeping your blood sugar under control. So always we should motivate the patient to record the information. Moving to identify who will follow up with patient. So who will follow up with patient? Depends on the purpose of the communication. It could be the primary care clinician. If the follow-up is complex or sensitive, the primary care clinician may need to follow up. It could be also the nurse and medical assistant. The nurses and medical assistants have the training and have the expertise to follow up with patients, to review things like blood pressure, blood glucose values, etc. Also, it could be pharmacist. A pharmacist, if you have one in your organization on site, is an ideal clinician to follow up with patients about their medicine. It could be also the other office staff. The front desk staff can follow up with patient to schedule appointment, confirm that patient have followed through with referrals, and provide patients with information about community resources, etc. Moving to choose the way your office will follow up. So the way of follow-up could be the phone. So talking on the phone allows patient to ask questions and staff to reiterate important points. Also via secure email. So secure email is part of many patient portals and can be an effective way to communicate with patients. And texting, for example, for patients who use text messaging, this can be effective for sending patient reminders and answering quick questions. And there is also another way, it's the post mail. So postal mail can be used to share information, such as normal lab results and appointment reminder, etc. And also you have the automated calling system. These types of system can be used for reminder and to collect information from patients, example, blood pressure. So you can type automated calling system into an internet search window to find a business that offers this service, for example. Finally, so initiate and track follow-up before we end with this track your progress. So initiate and track follow-up, work with clinical colleagues to identify the type of patient who would benefit from follow-up. Example, patients recently prescribed blood thinners. Identify the appropriate schedule for follow-up, like after a dosage change, etc. Establish system for tracking follow-up through the electronic health record or by using a computer-based calendar. We finish with the track your progress in this how to encourage patient to follow up. So track your progress, select the records of a sample of patients who should have received follow-up after a recent visit, example, patient with heart disease. Count the number of patients who received follow-up action that were scheduled in your tracking system, and count the number of follow-up action, like phone calls, emails, letters, etc., that were performed within the desired time frame. Okay. So we finish with this session. If you have any question, I'm ready to answer. Before we move to the second and the last session for today about the assessment and rehabilitation of lower limb amputation due to vascular disease. Okay, thank you. So we will have just 5 minutes break and we will be back on 11:20, so 20 past 11. Thank you. Hello again. Can you hear me? All is good? Can you see the slide? Yes, thank you. So this will be the last session for tonight. It's about assessment and rehabilitation of lower limb amputation due to cardiovascular disease or vascular disease. So as a definition of the amputation, just to like a quick reminder, so it's amputation at the loss of removal of a body part such as a finger, toe, hand, foot, arm, or leg. It can be a life-changing experience affecting your the ability to move, to work, to interact with others, and maintain independence. So continuing pain, phantom limb phenomena, and emotional trauma can complicate recovery and the rehabilitation program. Okay. So what are the causes of amputation? The amputation, you have the diabetes and vascular diseases, traumatic amputation, cancer-related amputation, amputation for severe infection, congenital amputation. So there is the causes of amputation by person. You have the neuropathy and vascular condition, 81.9%. So almost 82%. As per the cancer is 0.9%, the trauma is 16.4%, and congenital anomalies 0.8%. So the coming back to the traumatic amputation. So the traumatic amputation, a person can experience this traumatic amputation from a motor vehicle, for example, occupational or industrial accident, or combat injury. So traumatic injury account for about 45% of all amputation. So a body part can be cut off or torn away in a surf accident, or on a severe accident, excuse me. So, or it can be so badly damaged from a crash injury or severe burns, for example, that it cannot be saved. So as per the amputation or diabetes and vascular disease, it's about 54% of all surgical amputation result from complications of vascular diseases and other conditions that affect blood flow, such as diabetes and PAD, peripheral arterial diseases. So the chronic vascular problem can lead to tissue death in toes, feet, and legs of patients undergoing amputation. For complication of these diseases, nearly half will die within 5 years of the amputation procedure, unfortunately. Moving to the cancer-related amputation, so removing a hand, foot, arm, or leg to prevent the spread of certain types of cancer account for less than 2% of amputation. Cancers such as sarcoma can affect bone and soft tissues in the limbs. And if the cancer is too large or aggressive to be removed, if it's recurring, or if it extends into the nerves or blood vessels, amputation might be necessary, might be the solution. Advanced cancer affecting the upper leg can result in an amputation procedure called hip disarticulation, which removes the entire femur from the pelvis. Amputation for severe infection. So severe sepsis is also called septicemia or blood poisoning. It happened when drug-resistant bacteria overwhelm the body and spread throughout the bloodstream. So sepsis can affect blood flow and cause tissue to die, especially in the toes, fingers, hands, and feet. So severe sepsis can be deadly if antibiotic medicine cannot control the infection. What is the congenital amputation? This is not a procedure, but a term that refers to a missing or incompletely formed hand, foot, arm, or leg that is present at birth. So children who are born with congenital amputation may undergo surgery later in life or be fitted with artificial limbs in the child. So parents and care team determine that such intervention might improve the child function and well-being. Allow me here to talk about the types of amputation surgery. So the surgical approach depends on the affected body parts, the reason for the amputation, and the extent of bones and tissue damage. So we have the upper extremity amputation, lower extremity amputation, and for sure we have the double amputation. It's like partial hand amputation, so removing part of the hand, or wrist disarticulation, so removing the hand after separating it from the lower arm at the wrist. We have also the below the elbow amputation, so removing part of the lower arm by cutting across the bones of the lower arm. We have the elbow disarticulation. We have the above the elbow amputation, so removing the lower arm. We have the shoulder disarticulation, also removing the entire arm after separating it from the shoulder. And we have the 4/4 amputation, so removing the arm and part of the shoulder. As per the extremity amputation, which is our topic today, so it's partial foot amputation, removing part of the foot, ankle disarticulation, below the knee amputation, knee disarticulation, so removal of the lower leg by separating it from the upper leg at the knee. Above the knee amputation, it's about remove of the lower leg, so the knee and part of the upper leg by cutting across the upper leg bone. We have the hip disarticulation and the pelvic amputation or hemipelvic ectomy, so removal of the entire leg and part of the pelvis. And finally, we have the double amputation. It's the removal of both hands or both feet or arms and leg, so removing of two of the extremities. Type of the upper extremity amputation, as we said, we have the partial hand amputation, wrist and articulation, and as we said, also we have the hip disarticulation. So what is the difference between transtibial and transfemoral prosthetic use? So you have the transtibial prosthesis and transfemoral prosthesis. So the transtibial prosthesis can be done in sitting, can be used to add sit to stand, add sitting balance and transfers, lower energy expenditure in gait compared with transfemoral level, which is need more energy, lower risk of falling, and always for the transtibial prosthesis, usually comfortable to sit in and can be used purely cosmetically. As per the transfemoral prosthesis, ideally done in standing, therefore requires balance and frequently use of both hands. So we need the both hands to find the balance. Does not help the patient to stand up, can make transfers more difficult, higher energy because we don't have the knee, so we don't have the quadriceps. So it's obvious that it will be a little bit difficult, more difficult. So higher energy consumption in gait compared with transtibial level. With the transfemoral prosthesis, we have higher level or higher risk of falling and tendency to be uncomfortable if sittings for a prolonged period due to high level of socket anterior. Okay. The amputation surgery team. So we have the orthopedic, the orthopedic oncologic surgeon, who can work also with a plastic and reconstructive surgeon, along with a range of nurses and surgical technologists to perform a surgical amputation procedure. So together, they remove the diseased or damaged body part, and then they work with the remaining bone and soft tissues to shape the stump. So the surgical team may form the soft tissues at the end of the limb to help accommodate a prosthetic or leave bone in place for subsequent osseointegration. So we will talk about this later on. Surgical approach to amputation. Some of the common amputation approach is the standard amputation. We have the osteon integration amputation and the rotation plasty. Talking about the standard amputation, the surgeon removes here the limb and anchor muscles to the cut end of the bone and cover it with skin. So if the plan is to provide the patient with an artificial prosthetic leg, the terminal limb needs to be sufficiently padded with the patient's soft tissue so that the prosthetic is comfortable and can bear weight without causing pain or infection and without tissue breakdown. Talking about the osseointegration, surgeon remove here a body part and insert a steel implant into the stump of the leftover bone. A prosthetic can attach to that implanted piece. So when used for a leg amputation, this procedure can enable the leg and hip bones to absorb weight bearing instead of the soft tissue left behind. So standing and walking feel more natural to the patient. And the third one is the rotation plasty. Rotation plasty, which might be a choice for some patients with a tumor in bone or soft tissue. Surgeons here remove the part of the limb where the cancer is, and any healthy tissues below the tumor is turned around and reattached. For example, if cancer surgery requires amputation of the person's knee, so the bone and tissue of the ankle that on that leg may still be healthy. So a rotation plasty can rotate the lower leg and reconnect it so that what was the ankle joint becomes a substitution for the knee. So we use the ankle joint as a substitution for the knee in the place of the knee. Successful rotation plasty can allow some patients to use a prosthetic lower leg and enjoy mobility and even participation in active and sport. Assessment of the amputee. So assessment of a patient having an amputation should begin as early as possible. This could even be before admission to hospital for the either pre or post surgery. So in fact, the decision here to amputate should be made by this team, wherever possible. So this could even be before admission to hospital for the surgery. It's especially important if there are issues associated with wheelchair accessibility within the home and likely support required. So either pre or post surgery, it is of utmost importance to have a discussion with the patient about his short-term and long-term goals, as well as specific expectation and feelings they might have regarding the survey rehabilitation. So why we do the assessment? So to assess the most appropriate level of amputation, first of all. So not only according to tissue viability, but also the likely future potential mobility the patient may have. For example, is preservation of the knee joint paramount. Usually this would be the idea in order to maximize function and future mobility potential. But if it is fixed in flexion, for example, and distally likely to be a pressure area, so if the patient is not mobile, maybe this is not the case. So on the other hand, it may still be worth preserving if the contralateral limb is also likely to require amputation in the future. So this is to assess the most appropriate level of amputation. It's very important. So the second one is to prepare and inform the patient and their family or carers. So to prepare and inform the patient and the family, so the hospital, such as, for example, those produced by the Circulation Foundation. So many areas such as peripheral vascular disease, intermittent claudication, angioplasty and stenting, bypass surgery, and amputation to support local information. To discuss, third one is to discuss the realistic potential level of mobility. So to discuss this level of mobility with patient and family, whether this is likely to be using a wheelchair or prosthesis depending on the finding of the assessment. So it's important to be open and realistic from the start. So we should be, we should say the truth. We should be realistic in order to facilitate adjustment to their situation and to minimize problem resulting from misinformation. Moving to the order appropriate wheelchair and stump board if needed. So it's available as soon as possible. We should make it available as soon as possible. So talking about the optimized pain relief pre-op and post-op, discuss pain relief here and possible phantom limb sensation and pain post-op. So we should explain to the patient and the family about the pain he could feel it after the operation. We're gonna talk about this all kind of pain later on. To refer to other members of the team as required, such as occupational therapist, psychologist, podologist, or prosthetic service, dietitian, specialist nurse, etc. Or, for example, wheelchair services, social services, and other medical specialists such as Center for Diabetes, for elderly care, neurology, rehabilitation, medicine, etc. And to offer support from other amputees, if appropriate, either locally or through national organizations such as the Limbless Association, for example, and to begin discharge planning, whether the patient will be able to return home or will need rehousing or adaptation to be made, so a care package or admission to a residential or nursing home. The final point is to plan pre and post-operative physiotherapy intervention through the settings of realistic goals with the patient. Let's here talk about the physical assessment. So the physical assessment could be done pre or post amputation and should be tailored to the specific patient. We have the chest and respiratory assessment as needed. So it's an inspection of the residuum of and remaining limbs, pressure areas, and pain. And we have also the wound assessment, the wound approximation, the peri-wound erythema. Normally, after 70 hours, the erythema due to surgery should not decrease, and but an increase might be a sign of infection. So wound drainage, note any quality on or quantity change of the drainage. So moving to the presence of scar tissue and skin graft, conditions of the contralateral limb foot also, and we should also do some assessment about the vascular, as the vascular exam, for example. When the amputation is due to vasculopathy, this exam should be done at every visit. So it's like the, for example, presence and quality of distal extremity pulses, the color, the skin temperature, etc. And we have also the assessment of joint integrity and range of motion and presence of contractures, especially of flexor of hip and knee joints. Also, we have the muscle power assessment and range of movement of upper and lower limbs, as well as trunk, especially core stability. And we have the hand function. Will they be able, we should know if the patient will be able to don and doff a prosthesis and to put it on or to move it, and use a manual wheelchair. And we have the neurological assessment, especially peripheral, protective sensation using, for example, this represent the pressure threshold to protect the skin from ulcerations. We have the pinprick sensation test, the ankle reflex, the Tinel's test of the residuum if a neuroma is suspected. And we have the activity of daily living, functional mobility also, like balance in sitting and standing, bed mobility, and ability to transfer and mobilize. Okay. Let's talk here about the most important parameter to take in consideration for prosthetic fitting. We should ask if that the person with an amputation want to walk, first of all, and will it be possible for the person with an amputation to walk? For example, a hip flexion contracture of 15 degrees or more makes fitting a prosthesis difficult. So if you have a flexion contracture of the hip more than 15 degrees, he cannot walk or cannot fit the prosthesis. Where will the person with an amputation walk? Will prosthetic rehabilitation improve the person with an amputation's quality of life? And finally, after the assessment, the team will base the decisions as to whether or not to supply a prosthesis on the balance of successful outcome when considering the different parameters such as the pathology, level of amputation, length and condition of the stumps, and the environment and individual wishes. Sometimes to supply a prosthesis, it will not be good for the patient. It will not be functional, so the patient will not be functional. But sometimes it's aesthetic, so we can provide him a prosthesis just for aesthetic consideration. So patients are unable to achieve the following, they are unsuitable for prosthetic rehabilitation. So if the patient cannot achieve this point, it's unsuitable for prosthetic rehabilitation. So if he cannot transfer independently from a seat to bed or to chair or toilet and back using a standing pivot transfer, if he cannot push up from sitting in a wheelchair to standing independently in a parallel bar, have independent standing balance, cognitively unimpaired, be able to follow instruction, process new information, and remember it over a period of time. Also, with the aid of an early walking, such as PPAM aid of Ferburet, mobilized within the parallel bars, the patient should be able to achieve 6 to 10 length repeatedly throughout a treatment session on a regular basis during their initial phase of or rehabilitation. If the patient could not achieve or do this point, he will be unsuitable for prosthetic rehabilitation. Excuse me. The following areas would cause concern and would impact prosthetic rehabilitation. The muscle weakness in all four limbs, the poor hand dexterity with the patient unable to manage Velcro fastening or straps or de-locking mechanism. If the patient is unable to wash and dress independently, if he has like other pathologies like respiratory problems, poor cardiovascular states, etc., and if he presents poor motivation, issues of concern around social support and home environment. Treatment modality to prevent complication include breathing exercises, respiratory exercises, range of motion, passive and active, resistance exercises, desensitizing techniques, stump management like dressing, prevention of edema, wound healing, and managing the management of pain. Also bed mobility and transfers, positioning, walking, and wheelchair use. Breathing exercises, keep breathing exercises and relaxation exercises will help to increase vital capacity, decrease anxiety, and prevent bronchopneumonia. About the active range of motion, it's amputated site from the first post-op day unless the post-surgical dressing restricts their motion. So we should first do the hip flexion, extension, adduction, and abduction. Doing the knee flexion exercises for below knee amputation. Amputated site from the third post-op day to reduce edema for the below knee amputation should perform alternative knee flexion and extension. The knee disarticulation and transfemoral amputation should perform alternate hip flexion and extension, hip adduction and abduction. These active exercises must be performed at regular intervals during the day, 10 repetitions per hour, and bilateral activities often achieve a more vigorous contraction on the amputated site. Resistance exercises from the first day post-op, isometric contraction of the quadriceps, isometric contraction of gluteal muscles, adductors, and hip internal rotation, strengthening exercises of the sound lower limb. From the third post-op day, we should start resistance exercises of the upper limbs and resistance exercises of the torso. This is some figures about the passive range of motion. So passive extension of a transtibial residual limb. The physiotherapist's hands should be positioned as proximal as possible to avoid any contact with the end of the stump, which is a very sensitive area. And we do the passive movement at the passive range of motion. We have also the massage, tapping, desensitization, which is very important, and scar mobilization. Starting with the desensitization is believed to reduce pain, help with tolerance and touch in the residual limb, and may help the patient with an amputation adjust to his new body image that now include limb loss. So massage also and tapping can be started early on and could be done over the soft dressing or when it's off. So all this technique could be done by the therapist and also by the patient himself or the family members to do. We can also instruct the patient how to perform desensitization and distraction technique to reduce the phantom pain. So to help to make the residual limb less sensitive to touch and will improve the tolerance to touch 2 to 3 times a day when the soft dressing is off. This could be done during or after bathing. Start also by using a soft material like a cotton ball to gently rub the skin in a circular motion. Progress by using a rougher material like a paper towel, and then progress to a towel or cloth until you can tolerate this material. For the massage, so massage, we should massage the entire residual limb. We should be cautious over the suttered area. Once the sutures clips are removed, you can increase the pressure and the deeper muscles and soft tissues. As per the tapping, the residual limb should be tapped with finger tips. When the sutures or clips are still in, and then we should gentle tapping, and could be done over the clips line. So this could also be done over the rigid or soft dressing. Scar mobilization, it's important. So this will keep the scar from adhering to the underlying tissue, as it could be the cause of pain and blisters when the patient starts wearing a prosthesis. So the patient can do this also daily when taking a bath, for example. If the therapist will do it, so we should place 2 fingers over a body portion, and by keeping the fingers on the same spot, make a circular motion for 1 minute. Repeat this over and around the bone on the residual limb. Here we should talk here about the post-operative dressing, which is also important to treat the to reduce the swelling, to promote limb maturation and prevent contractures. So there is 2 major classification of post-operative dressing, so that are commonly used. So soft dressing and rigid dressing. So soft dressing, quickly, its descriptive studies indicate several disadvantages of soft dressing, so such as high local or proximal pressure, tendency to loosen or fall off, limited mobilization, and extended hospital stay. So we prefer to put the rigid dressing. Rigid dressing have been used as best practice for post-operative stump management for many years. So they come in 2 types: non-removable, high-length cast, which protect the stump and maintain the knee in extension, and the removable rigid dressing, where the cast includes the stump to just below the knee, thus allowing the amputee to have knee flexion and are easily removable to allow inspection of the stump. Wound healing. So wound healing is always a cause of concern, but especially in the vascular population and people with diabetes, it's really a concern. So adequately controlling edema of the stump can assist with healing, but some evidence also support the use of low intensity laser in order to facilitate and speed up wound healing, and especially in diabetic patients. Talking about the pain, which is also a important concern for the people with amputation. So pain is a very common physiological stressor that occurs during the acute post-operative period and affect the patient's ability to learn new skills. Adequately controlling the new amputee's level of pain greatly facilitates their early rehabilitation. So here the physiotherapist should take this into consideration and treat patients shortly after receiving their pain medication. Controlling edema in the residual limb throat positioning also assists in relieving acute post-operative pain. One of the physical therapist modalities or physiotherapy modalities that has been proven to be effective for the management of phantom limb pain is a 60-minute application of transcatheter electrical nerve stimulation. And also we have the mirror therapy. The bad mobility is also important for this kind of patients. So it's the mobility of bridging, rolling, sitting up in bed, scooting over to the side and lying and sitting, moving up and down on the bed, push up using arms after drain has been removed, balance in sitting on the side or with legs on the bed. So this is what we were talking about. Bridging, do the bridge here. So moving up his body by putting pressure on the leg and on the trunk. Rolling from one side to the other. Sitting up, so for patient bilateral amputation, it's just sitting down in the or sitting up in the bed. Doing the transfers, so standing pivot transfer for a patient that can participate only partially, backward forward transfer for patient with a bilateral amputation, and lateral transfer with a sliding board transfer, so standing pivot transfer. And this is the side pivot transfer. This is a backward forward transfer from the wheelchair to the bed. This is the lateral transfer, which is sliding board, and lateral transfer with a sliding board. This is important. So bed positioning for transfemoral and bed positioning for transtibial. For both of them, for the transfemoral, keep the above knee residual limb adducted while in bed, and keep the above knee residual limb abducted while in bed. This is do not keep the above knee residual limb abducted. We should keep it adducted inside. For the transtibial, keep the knee positioned in extension while in bed. Do not place a pillow under the knee while in bed, because it will lead the knee for a flexion more than 15 or 20 degrees, and then we cannot put or we cannot provide a prosthesis for this patient. Sitting in a wheelchair for transtibial, keep the knee positioning in a extension when sitting. Do not keep the knee in a flex position when sitting, for the same reason as I told you before. The important stages of grief. We have first of all, the patient feels like the denial, and then anger, and then bargaining, and then depression, and at the end, the acceptance. So the denial, it's often manifest as a refusal to engage in discussion for them to ask basic question about the planned procedure. So a minority of amputees experience denial in relation to accepting their impairment. As per the anger, which may be direct towards the medical team, with expressions of being cheated or tricked into agreeing to an amputation. It's like refusing the situation. Bargaining, feeling of guilt and second guessing on things past or what that should have been done differently. And then we have the stage of depression, taking the form of learned helplessness, feeling of passivity, and being overwhelmed. Finally, the acceptance stage, which may not be reached until the patient is into the rehabilitation process. So stages of adaptation. It's important also to talk about the stages of adaptation. It's useful to think of the process of adaptation as occurring in 4 stages: pre-operative stage, immediate post-operative stage, in hospital, and at home rehabilitation stages. So for the pre-operative stage, among amputees for whom there is ample opportunity to be prepared for surgery, approximately a third to a half welcome the amputation as a signal that suffering will be relieved and a new phase of adjustment can begin. So there is a symbolic concern here, such as changes in appearance, losses in sexual intimacy and perception by others, and disposal of the limb. The second stage of adaptation is the immediate post-operative stage. This period may last from hours to days, depending on the reason for the amputation and the condition of the residual limb. Psychological reaction for the patient noted in the phase or concern about safety, fear of complication, and pain. And in some instances, loss of alertness and orientation. In general, those who sustain the amputation after a period of preparation react more positively than do those who sustain an after trauma or accident. As per the in-hospital rehabilitation, the most critical phase, and this phase presents the greatest challenge to the patient and to the family and the amputations team, for sure. So initially, the patient is concerned about safety, pain, and disfigurement. Some individuals in this phase experience and express various kinds of denial, shown through competitiveness and competitiveness. Finally, at home rehabilitation, it's during this phase that the full impact of the loss becomes evident. So a number of individuals experience a second realization with attendant sadness and grief. So there is a varying degrees here of regressive behavior may be evident. So such as reluctant to give up the sick role, like a tendency to lean on another beyond what is justified by the disability. So it's like doing a retreat to a baby talk or something like that. So some resent any pressure put up on them to resume normal functioning. For so this is it's a critical stages when we are at home rehabilitation. So the interdisciplinary team approach, talking about the interdisciplinary team approach, which is very important for the patient center. So team management reduces hospital stays significantly and increases the long-term effectiveness of rehabilitation. So the amputee rehabilitation team should include the surgeon, the surgical nurses, prosthetist, physical therapist, occupational therapist, social worker, vocational counselor, and if indicated, for example, if it's in need, the psychiatrist or psychologist. So each member of the team is in a position to address one aspect or another of the patient. The involvement of members of the family at all of the stages can be of tremendous help. So perhaps the most valuable contribution of the team approach is the facilitation of a more rapid return to familiar surrounding and to independence. As per the treatment of psychiatric illness that precedes amputation can carry benefits for the rehabilitation process. So failed, for example, suicide attempts with resultant amputation may present particular challenge of successful rehabilitation. Talking about the complication of the post-amputation, which is also important, we have the, as we said, the edema, wound and infection, pain, muscle weakness, joint instability, autonomic dysfunction, and if there is a osseointegration specific complication. Talking about the muscle weakness, which is important, and the joint instability. So after amputation, it's not uncommon for patients to experience pain, muscle weakness, or instability in structure not directly associated with amputation. So these compensatory structures are the muscles and joints that are required to perform additional function post-amputation, often resulting in stiffness, spasm, or pain. The effect of bad rest and reduced mobility are also well documented. Deconditioning results is diminished muscle mass, reduced muscle strength, and changes in cartilaginous structure. Range of motion exercises should be incorporated to avoid contractures, as well as bone lying to prevent hip flexion contractures. A sandbag could be placed next to the residuum to prevent a hip abduction contraction, for example. Physiotherapy regimes should consist of the following elements: range of motion of movement exercises, strengthening exercises, stretches, core stability, early mobility practice, transfer practice, balance exercises, and passive range of motion aiding and gait re-education. Allow me here to talk about the phantom limb pain, which is very important in the amputation. So what is the PLP or phantom limb pain? It's defined as pain that is localized in the region of the removed body part. So it's a poorly understood clinical phenomenon that remain the subject of intense research due to the acute and the chronic nature of the condition. It's reported to be as high as 60 to 80% in patient post-amputation, and risk factors include chronic pre-amputation pain and post-operative surgical pain and psychological distress. What is the description of the PLP? The phantom pain often described as crushing, bruise twisting, hot iron, burning, tingling, cramping, shocking, shooting, etc. Like pins and needles, this kind of pain. As per the localization, tends to localize to more distal phantom structure like finger and toes, and it's in prevalence, it's in early stage 60 to 80%, so independent of age in adult, gender, level, or site of amputation. So in PLP, it's normal to work about or to do the mirror therapy. The mirror therapy, it's really important to reduce the phantom limb pain. So what is the mirror therapy quickly, because it's really too long to really explain this technique. But as a definition, the mirror therapy is a therapeutic intervention which has been shown to affect motor and sensory process through the relative dominance of the visual input it provides. What are the effects? So is created by viewing a reflection of the intact limb through a mirror placed where the amputated limb would have existed. So we put a mirror, بنحط مراية, and we ask the patient to move the existing limb. Most of the evidence for this intervention comes from case studies and anecdotal data, which only a couple of well-controlled studies. Moseley argued that while mirror movement may expose the cortex to sensory and motor input, so the therapeutic effect is magnified if cortical networks are gradually activated using limb recognition and motor imagery, and finally mirrored movement. So this sequences of cortical exposure has become known as graded motor imaging. To finish this presentation, we're gonna do like a quick review about the exercises for amputee. This is some kind of exercises. So prosthetic rehabilitation program exercises: hip extension, hip abduction, as you can see, hip flexion, back extension, etc. We have also the proper residual limb positioning, how we should position, how should we position the limb, okay, the residual limb position. even on the wheelchair or the bed. And the exercises had on wheelchair to mat transfer, how to move from wheelchair to the mat or to the bed. Some exercises, balancing activities, lateral weight shifting and balance orientation from right to the left. Always between two bars, parallel bars. Okay, forward and backward weight shifting and balance orientation. So also we have the stool stepping exercises. So just ask the patient to step on. And sound like stepping is designed to orient the amputee to gait biomechanics. Also helping the patient to do the rhythmic initiation design to promote transverse rotation of the pelvis, to do just the rotation of the pelvis. Resistive gait technique. We have also the passive trunk rotation, which will assist in restoring arm swing for improved balance while walking. And the braiding is an exercise designed to improve prosthetic control, balance, and coordination. So we ask the patient to do like the catwalk or to do this branding. Transfemoral amputee running gait cycle. This is a cycle of the amputee running. Some exercises for the normal leg or the just do some concentrated contraction, static and eccentric contraction. This is the example of hip extension with or without resistance. Some exercises lifting the pelvis up to maximum, concentric from C to D and eccentric from D to C. It's the opposite. So this is a pulley treatment. Bring the leg backward without making any hyperload doors. Here also, this is a bicycle tube exercises. We call it bicycle tube exercises. A patient extends the leg while the tube gives resistance. So he just extends the leg against the tube. Abduction movement with or without weight. Bicycle tube exercises, patient abduct the leg, so abduct the leg against the tube, so the tube gives resistance. Squeeze the towel or cushion, which is between the leg, combine the exercise with other muscles like the back muscles. Also the doing the abduct leg using the tube. Doing also the leg forward while the tube gives resistance. Hip internal rotator and bicycle tube exercises. Patient brings the leg to lateral while the tube gives resistance. So we put the leg, the tube all around the legs. So this is the extend the knee while resistance is given. And ask the patient to do the full extension of the knee. Also here there is an isometric contraction, move the patella to proximal. This exercise can be done direct after operation of injuries. This is the bicycle tube exercise also. It's a patient stretches the knee while the tube gives resistance. So he can just work the extensors and like the quadriceps while sitting. Pulley treatment, patient stretch the knee while there is a resistance. So this is all the exercises we can do. This is the patient flexes the knee while the tube gives resistance. Okay, I don't know if we have time to do this case scenario. Okay, can do it quickly. It's so it's Tuesday morning, and you receive order to evaluate and treat the following patient. So Mr. H, 70 years old, man who underwent to a left lower extremity amputation Saturday, so like Saturday afternoon. What is the cause reason for Mr. H's amputation? History of diabetes with peripheral vascular disease and chronic non-healing foot ulcers. Very mild peripheral neuropathy. What is the level of Mr. H's amputation? It's transtibial amputation. Here we have all these the levels of amputation. We have the hip disarticulation, very short above knee, medium above knee, long above knee, and then knee disarticulation and short below the knee, and standard below the knee, etc. Okay, so to move to the level classification of amputation. So transtibial amputation, 54%. This numbers is worldwide. So transtibial, it's 54%. Transfemoral, it's 32%. Cement foot is 3%. Hip disarticulation, 1%. Upper extremity, 8%. Limitation of for Mr. H, impairment and functional limitation. For the impairment and limitation, we have the pain, decreased strength, range of motion, and decreased mobility, decreased skin integrity, and decreased endurance and psychological issues. And as for the functional, as per the functional limitation, inability to walk, work, or to play. What should be included in the early post-op care of Mr. H? Can you just tell me, answer with me this question? What should be included in the early post-op care for Mr. H? Can someone just give me some answers about this question? What should be included in the early post-op care of Mr. H? It's the first of all, we're gonna work for the range of motion, the positioning. Okay, someone is answering me. Psychological support, range of motion, yes. Position, yes. That's good. Any other answers? Okay, let's move on. So pain management, okay. So skin care, edema control, isometrics, exercises, strengthening of the upper limbs, so residual and remaining limbs, patient education, bed mobility, and transfers. And finally, the balance. What are patients' primary goals, outcome for, what are the physiotherapist primary goals, outcomes for Mr. H's immediate post-operative period? Ensure optimal wound healing, early preparation of the limb for prosthetic fitting, and maintain increased mobility, improve endurance, care of remaining. Okay, someone is telling me comfort, okay. Care of remaining limb, maintain increased range of increase range of motion and strength. Okay, let's move to the third question. How should the physiotherapist inspect Mr. H's wound? How should physiotherapist inspect Mr. H wound? It's by monitoring residual limb for shape, incision healing and closure, land, sensory integrity, volume, tissues integrity, color temp, and if there is a pain or not. How can you teach Mr. H scar management? Once primary healing is established, teach patient scar massage above a below incision, not across. Once wound well closed and no steri-strips, can begin gently to mobilize scar itself. So why is scar mobilization important? Tissue must be able to glide. Adherence promote shearing forces which lead to skin breakdown. What are common post-amputation sensation Mr. H may experience? As for your opinion. Can someone give me the answer for this question? What are common post-amputation sensations Mr. H may experience? Phantom pain, phantom sensation. Okay. عظيم عظيم. كلكم منتبهين معي. الحمد لله. Okay, so phantom limb sensation, 70% will experience numbness. So 70% of the amputation patients will experience numbness, tingling, pressure, itching, mild cramp in foot and calf. And the phantom limb pain, like shooting limb pain or severe cramping, severe burning in amputated foot limb, not psychological. And higher amputation, greater likelihood, evidence if the patient had significant dysvascular limb pain, a surgery are more likely to have phantom limb pain. Yeah, it's a high percentage. It's true. It's a high percentage. Yeah, unfortunately. So what are some strategies for treatment of phantom limb pain? Can you give me some answer quickly about what are some strategies for treatment of phantom limb pain? I told you about maybe 2 or 3, but there is more. We will see more than this. Mirror therapy, okay. Okay, let's move on. Patient education before surgery. So alert patient to issues of safety. Wake up in middle of night after recent amputation and fall when attempt to stand and walk thinking both limbs are intact. يعني المريض بيعتبر حاله انه او بينسى انه في amputation وبالليل يقع ما بيقدر انه يوقف. So he stand up and think that both limbs are intact and the amputated limbs are here. Carefully inspection of limb to neuromia or infected wound. Awareness is needed, yes. So mirror therapy for sure. Electrostimulation is good. Compression use of prosthesis, desensitization, and technique and heat is good. Medication, steroid injection, nerve block, relaxation, hypnosis, varied effectiveness. So, okay. Moving to why is compression bandaging important for all amputees? Why put the bandage important for all amputees? Okay, can someone, it's important for the prosthesis, okay, decrease pain, maybe. To avoid swelling, yes. We'll see. It's reduce edema, controls pain, enhance wound healing, protect incision during functional activity, facilitate preparation for prosthetic placement by shaping and desensitizing limb. So the first 4, so reduce edema, controls pain, enhance wound healing and protect the incision during functional activities required even if patient is not a candidate for prosthesis. حتى لو المريض منه بحاجة لطرف اصطناعي, so the bandage is required for the first point, to reduce edema, to control pain, enhance wound healing, and protect incision during functional activity. What are the most common contractures to prevent in Mr. H? Transtibial. In transtibial, we have the hip flexion, the contractures of the hip flexions, it's good to prevent it, and the knee flexion. As I showed you before, I told you before about the positioning of the amputee limb. So why? So long period sitting in a wheelchair or bed position of comfort is one of flexion. Protective flexion withdrawal pattern associated with lower extremity pain, muscle imbalances, and loss of sensory input from food. What contracture are common in a transfemoral amputee? So if the amputation is at the level of the femur, so it's transfemoral, so we should avoid the hip flexion, hip abduction, and hip lateral rotation. What should physical therapy rehabilitation include for Mr. H? So hip extension, hip abductor, adductor, and knee extension, general strengthening range of motion and of trunk and the upper extremities is important. Strengthening the abdominals, shoulder, the pressures at the elbow, it's important. Aerobic exercises to increase endurance, mobility, posture shifted up, back and toward remaining extremity, and skin integrity, residual limb care remaining. And also we should include the balance exercises. This is the references if you want to see it. And I want to thank you so much for your patience, and thank you so much for your attendance. I hope this the presentation was good and as expected. Thank you so much. So it's the last session for today. We're gonna see you tomorrow and the last day with the last 5 sessions. Thank you so much. Thank you. And have a good night.